Sheila Mane is a very, very close friend.
Supriya, Madam, we have started the recording.
Yes, yes. Thank you so much.
Yeah.
And good evening, everyone, and welcome to this AICOG training program on adolescent health, a beautiful initiative by ICOG. And at the outset, I would like to thank President Dr. Sunita Tandurwarkar and entire Foxy team and ICOG chair and my dear friend Dr. Parag Biniwale, the secretary of ICOG, Dr. Sarita, and entire ICOG team for putting together such a wonderful program for adolescent health, giving the due respect and time to adolescent health. Let me also thank the convener for today, Dr. Durga Shankar Das sir, who will be giving us an overview shortly. But before that, let me welcome everyone with these 4 words. हसरतों से हम आपकी राह सजाते हैं, सपनों की दौलत से हम आपको हर हर दर पर लुटाते हैं, ना कोई फूल है आज हमारे दामन में, आपके स्वागत पर हम पलके बिछाते हैं. So welcome everybody, and it's really an honor for me to coordinate today's session. And without much ado, let me invite the guests for today to give an overview and their pearls of wisdom. We have with amongst us, has Dr. Ashok sir joined in?
Yet to join.
No, Ashok is not
Acha.
there.
Then we have Dr. Sheila Mane with us, chairperson-elect of ICOG 2025, Vice President Foxy 2014, Chairperson Safe Motherhood Committee 2008 to 13, President BSOG, President BMS, National Facilitator for Adolescent Health WHO.
Thank you.
ICOG
Thank you, Supriya. We'll
yes,
proceed.
ma'am. If I keep describing your CV, I think it will take the entire 3 hours. So let me hand over to Madam for her pearls of wisdom.
First of all, congratulations, Supriya. Okay. And the Adolescent Health Committee, and we have a adolescent, we call you adolescent, as a convener and coordinator for this program. And I must congratulate the conveners as well as the coordinators for this program, very nicely conceptualized. I think yesterday program, you people have discussed most of the problems or the issues with PCO. And I think if I look at today's program, I think it is mainly covering the social aspects, which is equally important. There's so many social aspects are covered today because all this, behavior, teenage pregnancies, as well as if we talk about MTP, even POXO, then violence against these girls, as well as the school health program, peer pressure, and very good topic on assault survivor. I think that is also very important, as well as the spiritual health, none other than Madam. So I think today is the social aspect, and it is taken care so much in today's program, which is equally important, because unless and until we really know what is going on in their mind, it will be very difficult. And I'm thankful, Dr. Parag and Sarita, for giving me this opportunity. I think myself and Parag, we were together for WHO facilitators training, and we have spent
and Rosa
almost
and Rosa.
And Durga, yeah.
No,
So
Rosa,
and I
Rosa.
think, oh sorry,
Rosa
Rosa, yeah. And we really learned so many things. And thanks to Dr. Durusha, for enlightening us regarding the adolescent health, and Dr. Ashwini Bhalerao. I must remember Dr. Ashwini also. And we used to have 3 days program, and we have gone into all these aspects. And I think it is a need of the hour today. And I wish that the audience who is listening to us will try to spread this word amongst the community. Whatever we are talking, it is for the community today. Yes, we have to know the nitty-gritty of that, but for the community to spread a proper message so that we can run a clinic for the young people and we can give them a proper message. Thank you very much once again, and best wishes for the rest of the program and tomorrow's program also.
Thank you so much, ma'am. Dr. Ashok sir has not yet joined, so may I request our ICOG chair, Dr. Parag Biniwale. We have already got some advice from him yesterday, but sir, would you like to please address us before we proceed?
No advice, no address. Just a small correction. Today, you mentioned that the guest today, so Dr. Sheila Mane and Dr. Ashok are the hosts. They are not the
Yes, I
guests.
agree.
So this
Agree.
time, this year, we've done away with the chief guest, guest of honor, etc., because we want to focus only on the academics. So even if we start the first lecture early, I think our delegates will be more than happy. And I must welcome the past and the future of Adolescent Health Committee. I can see Dr. Rosa Olai, Dr. Girish Mane, and you are the future. And I've already started giving you a lot of instructions since yesterday. I'm sure you'll take this committee to a greater height. And welcome Dr. Sadhana Gupta, the Vice Chair elect. She will be addressing us tomorrow. So over to you, Supriya, and to Dr. Durga Shankar Das for today's proceeding. Thank
Thank
you.
you so much. And really, it's an honor that Roja ma'am and Girish, who have set the bar so high for Adolescent Health Committee, and it is going to be my duty to, try and match up to in whatever little way I can, to take the committee, if not higher, at least to the level that they have brought it to. Thank you so much, Parag, for the kind words. Now I will request Dr. Durga Shankar Das sir, who is the convener for today, to please give an overview of today's sessions. Durga Shankar sir, CV please.
CV,
Sir is the governing council member of ICOG and scientific committee chair, National Foxy ICOG conference, joint organizing secretary of Bhubaneswar AICOG, past chairperson, public awareness committee, Foxy. Sir, all yours.
thank you, Supriya, for your nice words. So I welcome everybody to the second day of Adolescent Health Certification course. So this today we have devoted to the adolescent reproductive and sexual health. May I remind you that India is a younger population. So our adolescents are a great number of population in India. Our adolescents are our future. So, looking after their physical, mental, social, and spiritual health is the key to prosperity of Mother India. So, adolescent reproductive sexual health we have chosen because nowadays still we are worried because of so much of teenage marriages, which contributes significantly to maternal death and child health. One of the great concern, particularly of me, there are very strong uh, contributions from the criminals, as a result of which, uh, as a result of which, uh, please, as a result of which, that the crime against adolescents are increasing. So, of late, government of India also realized that prevention, promotion, and protection of adolescent as a mark of adolescent reproductive and sexual health should be included in national program. It was included in RCH2, subsequently RMNH, CHA. So adolescent health, child family health clinics were installed. So here we at Foxy are determined to promote all sorts of health sectors of adolescents and prevent atrocities against women. With this, we are assembled here. We have assembled here to acquire the technical knowledge for promotion of adolescent health, thereby promoting maternal health. We must know maternal health is global health. So Mother India's prosperity rests on the promotion of adolescent health. With this, I declare today's session open.
Thank you. Yeah. Okay. Thank you so much, sir, for those kind words. And I think since we are here for an academic session, we'll, without much ado, just proceed with the academic talks for today. So may I invite the esteemed chairpersons for today? Can I have the CVs of the chairpersons? We have three very, very esteemed chairpersons for today, and that is Dr. Sadhana Gupta ma'am. Then we have Dr. Charuchandra Joshi sir and Dr. Manisha Ghate. Dr. Charuchandra Joshi is a consultant in OBGYN in Pune since 1984, president of Pune OBGYN Society 2011-12 and 2016-17. Sir will join us shortly. He is somewhere stuck in traffic. We have Dr. Sadhna Gupta, who is the chair-elect of ICOG. Madam is a professor and has affiliation to various organizations. Senior consultant and infertility specialist. She's a member of the National Academy of Medical Sciences, fellow ICOG and Indian College of Ultrasound and Maternal Child Health. And she has, of course, special interest in safe motherhood, advanced infertility, and high-risk operative obstetrics. Welcome, madam. And we have Dr. Manisha Ghate. She's president of the Chandrapur OBGYN Society 23-25, organizing chair of AMOC Chandrapur 2025, West Zone coordinator for Food, Drug, Medico-Surgical Equipment Committee 2018-20 for FOXY. She will also be joining us shortly. The chairpersons, please note there's a slight change in the sessions. Sampat Kumari madam has finished her talk yesterday. So in her place, I will be beginning the session with my talk on adolescent nutrition, after which we will have the rest of the sessions. So now may I invite Sadhna ma'am to please start the scientific session. So immediately I can, put my PPT on. Yes, Sadhna ma'am.
Thank you, Supriya. And it's like being ICOG Vice Chair elect and a very, very close association with ICOG. It is great to going through all certificate courses, which are really creating wonders. My hearty congratulations to Parag, Dr. Parag Viniwale, ICOG Chair, and Secretary Dr. Sarita Bhalerao. And Dr. Durga Shankar Das is today's program convener, and the program has been very, very well designed. So there has been change. So I think it is Dr. Supriya, you are going to speak on nutrition. So Dr. Supriya has been we congratulate her for being elected for the FOXY Adolescent Health Committee, and she is consultant OB-GYN and infertility specialist at Bhiwandi, and we have seen her working in Adolescent Health Committee, and she has a multifaceted talent. So Dr. Supriya, over to you. That nutrition and adolescent both are confused in today's social media word and noise, and hope you will throw deep light and give insight to our delegates.
Yes, ma'am. Thank you so much for your kind words. And immediately I will start with my presentation. Screen. Slideshow. Make it full screen from here. Is it visible full screen?
Yes, ma'am. Yes, ma'am.
Okay. So thank you, ma'am. And at the outset, let me thank Dr. Parag Biniwale once again, our ICOG chair, Dr. Sarita, ICOG secretary, Sadhna ma'am, Durga Shankar sir, and all those who are involved in the, putting together this program, Sampat ma'am, Dr. Supriya Jaiswal, for allowing me to talk on a very, very important topic, which is so very neglected by adolescents, and also it forms the basis of health. So let me start with a few words showing the importance of food or of diet. कि खाने की तारीफ दिल ऐसे फरमाए जैसे मटर के साथ पनीर मिल जाए. खाने की तारीफ दिल ऐसे फरमाए जैसे मटर के साथ पनीर मिल जाए. आपको देखकर दिल ऐसे पिघल जाए जैसे गर्मा गर्म रोटी पर मक्खन फिसल जाए. So we all know that food is a very important part of our, our basic makeup, and we have to give it due importance. The overview of today's program presentation will be about the nutritional requirements that are specific to adolescents, problems faced by adolescents as far as nutritional requirement completion is concerned, the changes that are expected in puberty, including the hormonal influences, or eating disorders specifically which come up in this age group, and some strategies by which we as clinicians and caregivers can make a difference. Now we know the period of transition from childhood to adulthood is called adolescence, and during this phase there is accelerated physical, mental and emotional development. And in adolescent age there is an increased demand for energy, protein, vitamins, minerals and generally all food nutrition. Nutrition is affected by pubertal development. In pubescent age, we have full sexual maturity that is taking place with biological, physical, and psychological changes. An adequate and balanced healthy diet during infancy, childhood, and puberty is necessary both for fetal growth as well as normal pubertal growth. Girls begin puberty at an earlier age compared to past decades, and this is basically attributed to excessive eating, the wrong food, obesity, and exposure to lot of information and media. Girls begin puberty at an early age. Overweight or obese children are more likely to enter puberty early. And there is some evidence that suggests that obesity can accelerate the onset of puberty in girls and may delay the puberty in boys. It also triggers a growth spurt, which increases the nutritional requirement of the body, including macro and micronutrients. There is increased calorific needs, protein, iron, calcium, zinc, folate, calcium, all various aspects of nutrition are the requirements are going to be on the rise. And on the other hand, either they are underfed due to either poverty, lack of information, also due to food fads, or they are overfed leading to obesity. Severe primary and secondary malnutrition can lead to delay in onset and progression of puberty, and higher risk of anorexia nervosa and bulimia in adolescents may cause nutritional risk on pubertal development. Now we know most girls enter puberty between 8 to 13 years and boys between 10 to 15 years. The BMI and percent body fat has a strong association with puberty timing. Increased consumption of processed foods, high fat foods can be blamed for these phenomenon of early puberty in obese individuals. And of course, there are some controversies about the effect of obesity on puberty onset in males, but in girls particularly, this association has been studied at length, and definitely there is an association between the two. Now let us look at what are the specific nutritional requirements in this age. Now in energy, as far as the energy in the calorific need is concerned, there is increase in the metabolic demand because they are undergoing a growth spurt. They are undergoing lot of changes in the body. The protein requirement usually, the intake usually exceeds 1 gram per kg body weight to meet the needs of the growing body and for pubertal changes. And fats, foods low in fat, saturated fat and trans fat should be included in the diet when planning for adolescent diet. We all know that the energy requirement is going to be higher in this case. In general, nutritional requirement climb during pregnancy, peak during adolescent, and level off or even decline as the adolescent matures into an adult. Of course, then they are going to again rise when that girl is going to become going through pregnancy or lactation. Energy needs of adolescent vary greatly. In many households, the adults are outside the home and the teenagers have to do the role of gatekeeping of the home, the shopping, grocery, and choosing fast food, Swiggy, and those kind of options are now open to them, and often they are the decision makers, which prompts them to eat easily available foods or junk food. Snacks typically provide at least a fourth of the average teenager's daily food energy intake, and most often the favorite snacks are too high in unsaturated fat, sodium, too low in fiber and nutrition, and support the future health of the arteries can be can be seriously hampered. During the growth spurt, there is a linear growth increase markedly during puberty in both the sexes, approximately 5 to 8.3 centimeters per year in the prepubertal females, 5 to 9.5 centimeter in the males, and the weight gain also is going to take place between 3 to 9 kg per year. In girls, generally, the requirement is 1400 to 2200 calories, and girls between 14 to 18 usually need that is the prepubertal 1400 to 2200, and the actual pubertal or the late pubertal age around 1800 to 2400 calories per day. Active pubescent girls require more calories compared to the non-pubescent girls. Boys during puberty need calories more than the girls, because we know that the boys have more growth spurt, they have more protein requirement, because they have more muscle mass that it gets developed. So in the pre and pre-pubertal or just peripubertal stage, 1600 to 2600 calories, and in the later stages of puberty, 2000 to 3200 calories per day is minimal requirement for healthy body weight. Teenage athletes may require up to even 5000 calories, since they are burning more calories in when they are indulging in outdoor sports. Now, what are the common problems faced by adolescents as far as nutrition is concerned? First and foremost, physical and psychological pressure influences their eating habits. The advertisements, you notice any of the food advertisements or any other ad will specifically be directed to children and young adults, because they are the most impressionable. The business people are smart, they have this acumen that if they influence the children or the young adults, they are the ones who are the driving forces in today's home. It is no longer the time when the father or the mother dictated what will happen at home. Now the children dictate what will happen, and therefore they are at this age very impressionable. They are easily influenced by advertisements, by Instagram, by people talking about certain type of eating habits or certain type of foods. Adolescent girls may gain weight easily due to their psychological sex differences, and typically we know in females there is going to be little more fat deposition compared to the men, especially in the breast area, in the hips area. Also, where girls tend to have lesser physical activity compared to the boys. Teenagers mostly have the worst eating habits. They may skip meals because they want to lose weight. Most of them don't want to eat breakfast. Missing breakfast may be due to either eating disorders, due to peer pressure, because the peers tell them you are looking fat, or there is no time, they are too busy going for classes and extra tuitions. And of course, there is no nutritional awareness. They eat food items that are inadequate in calcium, iron, vitamin A, but high in saturated fats, sodium, calories, which are going to be harmful in the long run. They may feel uncomfortable eating in front of each other. They feel shy, so they don't want to eat when they are in public places, like when they go to school or college. They feel out of control when eating and unable to stop binging, especially if they are depressed, if they are lonely. Nowadays we know that children have thousands of friends online, but they have hardly one or two, not even one or two actual friends whom they can call their own, with whom they can share their problems, and who will not judge them. Alcohol, drug use, personal problems like mental problems can also influence eating habits. And realization that eating habits are abnormal is often absent. They feel this is how things are. They feel adults don't understand their problem. They feel their parents are trying to push them into doing things they should not, they don't want to do. And they are not mature enough to understand that these are going to be, in the long run, harmful to them. What are the psychological signs that we must look for, especially in young children, as far as their dietary changes are concerned? One is depression, shame, loneliness, guilt, or an emotional emptiness. They feel out of control when eating. Either they don't want to eat at all because they want to lose weight, or they are unable to stop binging. They eat as a form of escape from emotional depravity. They can feel uncomfortable eating in front of others, so they may stop eating altogether when they are out of the home. They are preoccupied by either dieting or losing weight or gaining weight, and they realize that their eating patterns are abnormal. The realization will come very late, and often they have low self-esteem. Hormonal influences, without a doubt, also play an important role at this stage. Now, this is a very simple diagram that shows how influences on growth and development can take place, as well as the secondary sexual characters. The hypothalamo pituitary axis is just maturing, and this leads to growth spurt in adolescence, increase in height, increase in muscle mass, the typical deposition of fat, as I already mentioned, especially in the female population, skeletal maturation, and secondary sexual character development. What are the common eating disorders that are common in the adolescent age group? Adolescent girls prioritize attractiveness and looks over health, over fitness. Boys overall do give importance to fitness, but they have a skewed idea about fitness. For them, fitness is a muscular muscle mass. So they eat all kind of wrong protein powders and can end up with renal problems on the other hand of the spectrum. Anorexia nervosa, bulimia nervosa, and binge eating disorders are common during this age group, and there is a predominance in the female population. What are the warning signs that a person may display that he or she is having eating disorders? People with eating disorders are at a very high risk of premature, not only death, but lot of other medical complications. They have a low self-esteem and body image, especially in the obese age. Not only obese, even the very lean and the thin have a very, less low self-esteem. They think they are too thin. People tease them. There may then the obese ones might try to do some dramatic weight loss, preoccupation with weight, food facts, and meal rituals, routine bathroom trips immediately after eating, binging or hoarding large amount of food, increased use of diuretics and laxatives. This is another, or the diet pills. So they feel that if they lose weight by using eating diet, having diuretics, they don't realize that it is not the weight that is lost, it is only the fluid that is lost. So also you're having laxatives, compulsive exercising, too much of exercising, and withdrawing from friends and activities, especially group activities. Now, anorexia nervosa is in a person who may be even a lean, thin person or an obese person. The impression of physical weight and shape is totally skewed in their mind, and it has a disproportionate negative impact on a person's self-esteem. And they compare themselves to idols who are totally not, have nothing to do with normal life. And that is the people from Bollywood and Hollywood who push for size zero. They do not realize that to get that size zero, lot of nutritional hampering takes place, and it is something that should not be indulged in young age, because they are growing. Their necessity for calories and certain minerals and vitamins is going to be there. Anorexia nervosa is usually a disorder in which the person restricts their food and beverage consumption due to a strong desire to remain slim and fear of gaining weight, to the extent that they may totally stop eating or eat very, very less, and then they become nutritionally deprived. Weight loss and nutritional imbalance as a result can result to serious complication, and there have even been deaths associated. Bulimia nervosa is a disorder in which a person eats in excess quantity, unable to stop, and sometimes to the limit that they may induce vomiting or take laxatives so that they can rid themselves of whatever they've eaten and again then go back and eat more. It generally starts in young people, early adulthood, and affects more. It affects more girls than the boys. Binge eating, already I mentioned, where the children find comfort in eating, and of course all the wrong stuff. They try to fill in the gaps in their emotions, in their psyche, by means of food. And someone suffering from binge eating disorder does this at least once a week, or at least three, for at least to total 3 months, can't seem to quit. Most of them, especially after COVID, the young children now, they don't sleep on time. They are awake to late hours of the night, watching TV, binge watching and binge eating, because usually when you're awake in the night and there's nothing much to do, you can find comfort in eating foods that are not really good for your health.
Sorry to interrupt you, ma'am.
Yes.
Your time is up.
Okay, I'll try to few slides I will skip. I'll just quickly go through the food fad. What is a food fad? It's a fad diet that is a weight loss program. Give me 5 minutes and I'll wind up. Fad diet is a weight loss program that aids or promises to aid dramatic results and typically does not focus on long term. Young children are more likely to go in for the fad diets. Why they seem to work? Because in the short term, obviously the calorie intake is restricted, so the person is going to lose some weight. But why they don't work is because it does not focus on the long term. It does not focus on the nutritional imbalance that the fat diets are going to cause. And by omitting certain foods and sometimes even entire meals, there are going to be deficiency in major nutrients, and this can especially impact the younger population because they are growing in various aspects of their body, their mind, their psyche. Uh, this is a chart which basically shows how obesity can influence puberty, and there are studies which show that puberty can come earlier in obese children, and it in malnourished children, on the other hand, puberty can come in delayed. Then what is it that we as clinicians can do? Not only will a nutritious diet help to boost immunity, boost immune system, but smarter food choices will also avoid depression and other mental illnesses, which now we recognize are on the rise. A diversified diet rich in fruits, vegetables, whole grains, nuts, legumes, omega-3 fatty acids rich food is likely to be the best diet plan. So intervention is number one, a healthy environment at home. Give some social training, skills training, ask the family to be supportive. The family should plan the meal such that they are average in calories and high in nutrition. Avoid binge eating. If they are indulging in any kind of eating disorder, they should undergo a psychiatric evaluation. Develop a plan wherein they can cope with their problems and give them a good diet plan. For example, I'll just come to that. So make a few suggestions for the
Supriya,
daily.
Supriya, sorry.
Yes. Last
Supriya,
two
sorry to
slides.
interrupt.
Yeah,
You're
yeah.
already 20 minutes from
Okay.
your.
Yeah. These are the last two
Just
slides.
wind up, please.
Yeah. So on most days of the week, try to be physically active, consume variety of fruits and vegetables, eat foods and few added sugar, less added sugar, saturated fats and sodium. Whole grain should be given, lean proteins, dietary items, and increase the strength of your body by some exercise. So this is a typical pyramid of healthy eating where the oil, salt, and the carbs should be at the apex of the pyramid, and the base should be made of grains, of legumes, of dairy products, non-vegetarian products, and so on and so forth. I think safely skip this, and I'll just go to, yeah, these are the few last two slides. Weight loss, if they want to desire, they should eat as often as at home as possible. More fruits, vegetables, grains, nut and fish. Keep a log of the food that they take. Include water at least 2 to 3 liters every day, and avoid empty calories through sugar drinks like soda and punches. Breakfast like a king, lunch like a commoner, and dinner like a pauper. If at all they have to do some binge eating, not binge eating, but eating some junk food, it should be only once a fortnight. We should call it a reward day and not a cheat day. It should be a reward for eating healthy for the remaining 14 days. Good amount of exercise, any kind of exercise like walking, jogging, running, cycling, swimming, whatever suits them best. Adolescent is a period of significant physical and sexual growth. Nutrition is an important aspect or attribute of the physical growth of adolescent. Inadequate nutrition during this time can have serious consequences through reproductive years, and therefore we should give due concentration to adolescents, especially when they arrive at this stage in life. We should make sure, for even if they come for any other reason, we must give them good dietary advice. Let me take the opportunity once again to thank entire ICOG team, and especially my friend philosopher guide Girish Mane for helping me with this very beautiful PPT. Sorry for overshooting, and over to the chairpersons to carry it forward. Thank you.
Thank you, Supriya. You have actually focused on all complexities of modern world and the changing the balance from parents to children. And we need to see, think your presentation that covers like a complexity of the world, but actually in India, we see across the section a highly changing, and many things are not. Actually, if you, like I see 50-60% of families are still very disciplined and balanced, and they don't have even money for all these Swiggy and the eating. And as a ICOG and as a Foxy, we must look into that also, that how we can optimize the resources on nutrition, not on the gadgets, not on the fancy thing, but that is the nutrition, which is the Indian philosophy.
Madam,
So,
perfect word you use, not fancy. We should encourage people to eat the local produce. Nowadays, people are behind fancy superfoods and they are not necessarily easily available. They are expensive. They may not be accessible. Small towns don't have, and people are mad over those superfoods. We should encourage them to eat local produce and let the family have at least one meal together. You know?
So thank you very much. It is unending, and
Yes,
nutrition has
ma'am.
become complex, and also the meal for the economic trade war also. So as a doctor, we need to be very, very careful. So thank you very much, Supriya.
Thank you, ma'am.
Durga, should I introduce
Let us see
who is
whether
that? Who is
Jairani
the,
has. Let us
who is
invite
the
Jairani. Go in the order. Yes, fine.
Jairani is there, and like Charu and Manisha is there, or should I introduce?
Yeah,
Jairani?
Manisha has joined, ma'am. Manisha has
So
joined.
please, Manisha, please introduce Jairani, and we congratulate
Madam,
Jairani.
Madam, good evening, ma'am. Just can Apurva can talk because I have to. I've joined in another system. There's some confusion in that. Can I have another 5 minutes?
No
So,
problem. No problem.
Yeah, sorry, extremely sorry. There was some
No,
trouble.
Apurva can
Apurva
take
has already
first.
joined. I think
Yes,
we can
sir.
go ahead.
Absolutely, sir.
Apurva, can you
Yes.
help me? Thank you,
Yeah,
Apurva. Thank you so
absolutely,
much.
absolutely, ma'am. And yeah, ma'am, absolutely.
Yeah.
Manisha, you are please introduce Apurva, and
Good
he's the
evening to all
yes.
my respected seniors and dear friends. I was listening to talk of Supriya ma'am, and there was so much to talk with it because that time is not enough to discuss this topic. But Supriya ma'am, the talk was excellent from your side. And let me take privilege to introduce the next speaker, Dr. Apurva Kumar Datta. Everyone in Foxy know him. He is the chairperson of the Sexual Health and STI Committee of Foxy. Editor Foxy Focus on Sexual Health. He has been editor.
Thank you so much, Manisha, ma'am. We are
Yes.
already running
Yeah,
short
yeah,
in
yeah.
time.
Yeah.
So thank you.
Dr. Apurva, the stage is all yours. Please start your.
Yeah.
Thank you.
Yeah. So at the outset, I would like to thanks to our ICOG chairperson Parag sir, all the ICOG team. Shadna ma'am is there, and Durga Das sir is there, and then Girish sir is there. And thank you and pranam to all the seniors and my regards. So after this power-packed performance by Supriya ma'am in a form of lecture, so he actually now it's a term of very different topic. And I think this topic is often misunderstood, mistreated, misinformed. That is the STI and RTI in case of adolescent. So as are my PPTs visible?
Yes, yes.
Make it.
Yeah.
You can go ahead.
Yeah. Yeah. So the objective of the session is the definition of the STI and RTI. What are the common STI and RTIs? The mode of transmission, the risk factor, the misconception related to the transmission, and diagnostic treatment and the follow-up. Now, first, we have always a confusion that what is STI and what is RTI, and are they actually the same or the different? So let me clear first that if the infection that is spread primarily from person to person through the sexual contact is known as the STI. So it's reflect the mode of transmission of the infection. Whereas the reproductive tract infection, that is RTI, is the infection which are present in the reproductive tract of an individual. So it's represent the site of the infection. So confused? Yes, I'm also confused when I first read it. So this actually particular PPTs make it very, normal. So what is STI? It includes the hepatitis B. It's included the oral and anal STIs and HIV. What is the RTI? It also includes the disruption of the normal flora, the infection following the procedures, the postpartum and post-abortal infection, and what's containing whole the STI and RTI are the gonorrhea, are the chlamydia, syphilis, synchroid, the human papilloma virus, and the herpes simplex virus. So these are actually different entire topic, but for namesake, we can take it as a STI in case of adolescent. So now, why should we worried about STI? We should worry, especially in case of adolescent, because it's caused the discomfort and pain, because it is spread quite easily. It can cause infertility, stillbirth, ectopic pregnancy, congenital defects in newborns. It also leads to the shame and guilt over the behavior that caused the STI, which make the people delay the treatment and often visit to the quacks. So this actually made the treatment of the STDs and STIs are more difficult. Now, how do STI spreads? So mode of STI infection is either the sexual route, it may be the anal, the vaginal, the oral, or it may be the RTI, for example, in case of mother to children, either during the pregnancy and childbirth or from the blood and the blood products. Now, are the sexual practice and risk of the STI? Yes, the sexual practice, whether it's a anal sex, whether it's a vaginal sex, and whether it's a oral sex, they all can lead to STIs. And the highest among it, the anal sex, and the lowest is the oral sex. But yes, they often cause, even the oral sex can cause the STIs. Who are at a risk of STIs? Anyone who has unprotected sexual intercourse with a person infected with the STI. Some people are more prone. Who are those people? Who have multiple sexual partner, who have frequently changes the sexual partner, or who have multiple sexual encounter without any protection, that is the condoms, are actually in the risk of the STI. So now coming to the adolescent. Why adolescents are more vulnerable to STI? It is due to the social, because they are socially very virulent, because they biologically, and because the systemic barrier, all the myths and misconception around the STIs during the around the adolescent is actually made the adolescent more vulnerable to infect with the STI and STDs. So, STI and RTI in adolescent, a report published by the CDC in 2017 that young people around the age of 15 to 24 year of age develop half of the all the new STDs and STIs. One in the four sexually active adolescent females have the STIs. One quarter of the adolescent and young adults in high risk group for STIs do not have the health care coverage, and only 11% of the teenager surveyed report getting most of their information regarding the STIs from their parents or their family members, and only the 40 to 50% of the adolescent are actually seeking the treatment from a doctors. So this is the very sad the affair of the STI and RTIs in adolescent. Now, what included the STI? I have already stated. It's included the HIV, the HPV, the gonorrhea, chlamydia, the herpes simplex, the hepatitis B, hepatitis C, syphilis, and trichomonas. So these are the most commonly STDs. Now, my dear friends, believe me, because my clinic is one of the first queer friendly clinic in the East India. So I am seeing that the incidence of the gonorrhea is somewhat increasing. Even this month only, and I have seen the 5 cases of gonorrhea. So please don't be so much that prejudgmental that STIs are actually reducing, the gonorrhea is reducing. In fact, it is now increasing. So we should be very vigilant. And when the adolescents are coming with us, you just take your some time and discuss about this STI and STDs. Now, the symptoms which actually usually patients are coming, the systemic manifestation of STI, for example, in the hepatitis, they have either secondary syphilis or there is a Fish-Hutch-Cuten syndromes or may present with the arthritis, may have the skin lesion, may have the proctitis or discharge from the vagina or from from the private part. So these are the different type of manifestation according to the type of what the infection they have. So what are the not causes of not seeking the treatment? Because they are confidentiality issues and a lack of privacy, non-ability of the specialized center for that. There is a poverty, there is a long queue, there is a reluctant to approach to the mail provider, the judgmental issue of the staff, the over perception of the cause of the disease, inability to understand the magnitude of the problem, and of course the social stigma. So these are the factors which led that they actually seek the treatment very late when there is already being damaged. So this is very important. Now, how to prevent it? So, STI is definitely a preventable disease, and identify of the high risk group is very important. And inculcation of the responsible sexual behavior, the contact tracing. PAP is where, in a case of older age group is definitely important, and promoting the human papilloma virus HPV vaccines at least 2 doses less than 15 year of age are more immunologic, and it is absolutely recommended. Even the government are now working on it, and we Foxians are actually working it, and we have a lot of program around the promotion of the HPV vaccines. So now coming to the what is responsible sexual behavior. Sexual responsible behavior is not hurting yourself and not hurting the other person. It included the A, B, C, D. That is the abstinence, that is be faithful, use the contraceptive and especially the condoms, the disease alert, get tested and treat the problem according to the diagnosis of the problem. So this is the responsible sexual behavior. So what is the, if you do not take a detailed sexual history of your partner on your date, you don't know him well enough to have sex. And safe sex is the sex with your faithful partner. That's all about the, in short, the STI and STDs in case of adolescents. So thank you so much for your kind listening. Over to the chairperson.
Excellent talk, Dr. Apurva, on this very hot and sizzling topic nowadays it is. But the things are sure that, yes, awareness is much, much, much required today also, in what setup India is growing now, because we are having so much of adolescent and young people population nowadays. What I think so, awareness is the key to all of the problems which we see around the STIs and the RTIs. And again, you have emphasized that the ABC of the responsible sexual behavior. Yeah, that we have to very much implement in our system, and surely we will see a lot of progress in this field from this. Thank you for giving the opportunity, and thank you for such an elaborated talk. Yeah.
Thank you so much. Thank you so much, ma'am. Thank you so much for having me. Yeah, I think there are some question I will directly answer in the chat box. So thank you so much to all the organizer for having me.
Thank you, Apurva. You have finished before time.
Yes, sir. Short, sweet, and crisp, sir.
So just
Yes.
add one line. What is the essential difference between STI and RTI? Are they same thing, or are they are not synonymous?
Absolutely, sir. They are not synonymous, and I have already stated at the starting, and that reproductive tract infection is actually, saying you, and that's what is the site of the infection, whereas the STI is saying you what is the mode of the infection. So, for example, if there is a disruption of the normal flora of the vagina, then it's absolutely this disease is included in the RTI, but it is not included in the STIs. So this is one thing, the differences. So this is main thing. That's why there is actually a very little difference between them, and we are basically focused on STIs because the RTI, those RTI which actually being treated, for example, gonorrhea, etc. So when you are treating the STI, actually majority of the RTI is already you are treated. So it is the difference is very slight, and we are more focused on the STIs because it is actually spread from from one partner to another partner. So this is the thing, sir. What do you say?
Okay. Dr. Manisha?
Thank you so much, Dr. Apurva and Manisha. Has Charuchandra sir joined in? Not yet. Then I'll request Sadhna ma'am to please introduce the next speaker for today, Dr. Jairani. Jairani, have you joined in?
Yeah, I've joined it, but network has some issues. I don't know. I've asked my people to check it. It's very unstable. I don't know. That is the reason that it's little difficult. Let me have a luck to join.
Okay, fine. Sadhna ma'am, will you please introduce Dr. Jairani?
Dr. Jairani Kamraj, we congratulate you for being elected for FOXY committee.
Thank you,
for
ma'am.
the
Thank you
violence
so much,
against
ma'am.
women.
It's all your love
And-
and blessing, ma'am.
We look forward for your great tenure, and she is a very well-known figure. Why you have like flashed off her CV? ICOG office, please flash off her CV. She has
Thank you,
been
ma'am.
the
Thank you.
Senior Consultant of Reproductive Medicine, Director Akash Fertility Center at Chennai. She has been the past President of Obstetrical Society of Southern India, Vice President TAPI and Joint Secretary JNFOG. So she has been awarded with a lot of medals and the awards, including Best Doctor Award of Chennai, Dr. Vijay Vadamalyan Endowment Gold Medal. So she has been the brilliant student right from the beginning, and a very good orator and a very good person and a dynamic person. So Dr. Jairani is going to a little bit what she is going to work in next 3 years, that is the sexual behavior in adolescent, and that is actually what's violence against women and the gender neutrality and is respect. It is all related to your future work in FOXY, and we look forward to hear from you. Welcome.
Thank you, ma'am. Thank you. Thank you so much. Thank you for your kind introduction. A very special thanks to ICOG, Dr. Parag sir, and all the conveners of today, Dr. Dash sir, and Girish and Sadhana ma'am. It gives me a great pleasure and honor, and I'm privileged to be here as a part of a faculty of this wonderful, ICOG class on adolescent sexuality. A very special thanks to the organizers. And I would like to, can I share my screen?
Yes, ma'am.
I couldn't see the, yeah, yes. Can you see my,
Yes, ma'am.
is it full screen? Yes?
No, ma'am.
Not yet.
Ma'am, slideshow.
Okay.
No.
It is not fitting to your Zoom window. Yes, yes.
It's perfect, ma'am.
It's full screen?
Yes, ma'am.
Okay. So is it full screen and it's moving? Slides are moving?
Yes, ma'am.
Okay. Thank you. Thank you. Thank you. Sorry for this technical clash. So we are now moving into a very important topic on the adolescent sexual behavior. So as rightly talked about the STI and HIV in adolescence by Apurva, we are here about the sexual behavior, which is very important as a part in the adolescence upcoming. So definitely adolescence is a period of transition from childhood to adulthood. During this, there is a lot of changes which changes the adolescence feeling and a lot of physiological, psychological, and social and biological changes which play a very important role in the adolescence, making them very important, having a problem related to the sexuality. So we know the development of sexuality, though it begins from the conception, it is shaped during this period. So this transition is very important when the child enters into an adolescence and then travel this adolescence and then goes into the adult stage. So the important part in this is their sexual behavior. So which is a very interesting and very intrinsic, and rather it is a very important unpredictable phase which happens in the adolescence. And it is rather a critical stage in the human development process. That's what we have to look into it. So it is a very important one, because many of the problems of adolescents go through in this phase is mainly a problem with their actions, their thought, their peer involvement, lot of social involvement, and their sense of identity and difficulty and consequence to how to react, how to act, how to respond to the peer interactions, and lot of things happens in their sexuality. So definitely sexuality cannot be defined purely as a biological changes, but it is also an individual which changes, which is mainly impacted by their physiological, psychological, social, familial, and also about all these situations. Everything plays a role. So it is actually a process where the adolescents experience a lot of emotions, urges, motivation, feelings, and lot of forms of different forms of attention, aspects of self, a feeling of a self-esteem, self-image. All these play a very important role in the adolescent sexuality. So it is very complex if you look into it. And very interestingly, the sexual behavior is totally unpredictable, and definitely it needs a lot of attention from the parental point of view, as well as from the elder point of view, as well as the social responsibility of every healthcare provider to look into the adolescents, to look into their sexual behavior, which plays an important role because of its impact on their very important part is their health. It is very importantly play a role, because if you look into the women, it play an important role in the form of a teen pregnancy, which can happen, and in the in form of infection, it could produce an STI and HIV. So all these things makes this sexual behavior a very important one in the adolescence. So by definition, the full range of thoughts an adolescent go through, feelings and emotions, his motivation and actions, which is related to sexuality. Like many
Dr.
questions.
Dr. Jairani, your slides are not moving. We
Yes,
are not
ma'am. Yes,
putting
now.
the first slide.
Yeah, ma'am. Yeah, ma'am. I'm
Okay,
talking.
fine. Okay,
I'm talking, ma'am. I'm talking about the introduction only, ma'am. So in that way, definitely all this definition, which is actually a crushes, fantasies, masturbation, dating, kissing, sexting, all these are a form of sexual behavior. So it is a normal developmental process which is shaped by the biology, that's the puberty, which is mainly ruled by the hormones, brain maturation, and the psychology, which is the identity of the emotions, and the context, which is the peer media culture. So this is the definition of the sexual behavior, where every aspect of this play a role in creating a situation and make them in their sexual activity, which is very important. So during adolescence, we know major biological and psychological development take place, and individual thoughts, perception, as well as response get very much colored sexuality. The myriad changes that occurs in this adolescence put them under a lot of stress, which may have an adverse physical as well as a lot of adverse psychological consequences. So it is very important for us to know about the problems of this sexual behavior. So the first question is whether the adolescent sexual activity is equivalent to an adult sexuality. That's the first question we come across. But when you look into it, most of this psychological, medical, epidemiological research clearly demarcates adolescent and adult sexuality, with different or many elements of sexual experience assumed to be inappropriate for adolescents and preserved for the adults. So that's very important. It is not the adult's sexuality now comes here. It is inappropriate for the adolescents to think of an adult sexual behavior. That's very important. So in addition, the broad social, cultural, the religious investments in the meaning of this words like virgin, all these are the example of this perspective. So we perspective the virginity and other things mainly with the broad biological thinking of this playing a role in the adolescent sexuality. When you look into the lot of data and researches, the sexuality is seen as a domain requiring adult maturity to experience and express. Adolescent sexuality is portrayed even in obtainability objective research as tentative, experimental, confused, inappropriate, and innatively dangerous. That's what they say about the sexual behavior in an adolescent when compared with the adult sexual behavior. In addition, many research stating that if the literature addresses the adolescent sexuality as an expression of risk-taking requiring a broad social efforts to suppress or to control. So that is why it is very, very important. So what are the components of the sexual behavior an adolescent go through? It could be an internal experience. It could be a self-directed behaviors. Internal experience, which includes their self-thoughts, fantasies, imaginations, motivations, which always make them attracted and crushes towards the opposite or even the same sex. And also about a lot of the curiosity, what they go through in their body changes like their menstruation, erection, nocturnal emissions, and even the changes in the bodily changes. All these things are an internal experience an adolescent go through. And self-directed behaviors like masturbation, exploring their own body, experimenting with the sexual identity. These are all something which is related to their self-related behavior. Interpersonal, which is always including a romantic behavior either with the opposite sex in the form of flirting, dating, holding hands, hugging, kissing, petting, and also sharing sexual images like sexting in the modern context. So this behavior, which includes all these self-directed behaviors, internal experience, romantic experience, and even the digital behaviors, all comes under a sexual behavior in an adolescent. So definitely sexual activity with the partners, it is a subset, either it could be oral or a vaginal or anal sex. Also, it's very much a profile or a diverse profile which is seen in the adolescent. So definitely all these are the sexual behavior. So this leads to mostly a sexual activity with the partners, either it goes to oral sex or a vaginal or an anal intercourse, or even an experimental, sometimes consensual, but also may involve some sort of a peer pressure, making them involved into a consensual act, and also has a risk related behavior like going through an unprotected sex with multiple partners or even a casual partners, or it may be influenced by the drugs and alcohol and also by the pornography excessively or excessively through that age. So all these things makes them into an behavior which we call as autoerotic behavior, where they do a masturbation which increases as a normal outlet for sexual tension, and the romantic attraction and dating which includes crushes, infatuations, relationship, and experimentation which is kissing, petting, and early intercourse, or a risky behavior which is an unprotected sex with multiple partners, sexting, pornography use. And it also includes a gender exploration and gender identity, which is a really an important questions related to the gender identity. So in our Indian setup, this is oftenly a secretive one. So, but in the Western countries, it has more open discussions, but still there is a high prevalence of early sexual experimentation. So all these are into the act of the age at the first sexual intercourse, and when they have the intercourse, how they have it, all these things make a very important role in the sexual behavior, which is ultimately the final risky things that an adolescent go through. So we all know the health implications of this sexual behavior ends in three things. One is the physical risks, which includes an unintended pregnancy, an STI, and also a lot of psychological risks in the form of anxiety, guilt, depression, and stress, and frustration, low esteem if it is unsupported. And a very important one is the positive aspects. Some way they explore their own body, which gives them a body confidence, may have an importance in building up a secure relationship and also have a long-term better sexual health. So that is a positive aspect of knowing their changes in their adolescent sexual behavior. What causes this basis? We all know the physiological basis, which includes the hormonal, the hypothalamus pituitary activation, which in the form of a rise in the LH and FSH, and thereby causing a changes in the testis and the ovaries, causing the release of the testosterone in the boys, causing the spermatogenesis and the changes in the boys, and the secondary sexual characters in the boys, as well as in the women. In the girls, it's an estrogen and progesterone, which causes a puberty either in the form of a menarche and the secondary sexual characters and mood shifts. And also there is a increase in the release of dopamine and oxytocin, which is always very important in the adolescents, making them feel a reward seeking, more of a bonding and romantic attraction. That is a one important aspect of the brain, the neurotransmitter changes which is happening in the adolescence. So in the brain, the development of the reward emotion system, which is mainly mediated by the prefrontal cortex, which is the cortex for the control and the judgment, play an important role in this adolescent age. So there is an imbalance which really causes lot of impulsivity, risk-taking behaviors, experimental behaviors, and especially experimental sexual behavior, which is the reason for this cause. So definitely this adolescence is a special phase of sexuality. Mainly we know pretty well the puberty causing a lot of hormonal activation and the brain development mismatch, which is very important. As the brain is developing, there is a lot of mismatch in the form of the rewarding system by the limbic system and the cognitive control, which is mediated by the prefrontal cortex, which plays a very important role. So we know pretty well the reward chemistry is by the dopamine, the signaling in the ventral striatum and the nuclear accumbens, making sexual stimuli a social approval feel especially very much salient. Whereas the bonding chemistry, it is mainly by the oxytocin, which is released with a touch, orgasm, foster, pair bonding and intimacy, which is mediated by the accumbens and the prefrontal cortex. So the sexual behavior is not controlled by one center, but has a lot of interconnected network. So the hypothalamus, amygdala, nucleus accumbens, reward center, prefrontal cortex, hippocampus, everything plays a role in making this task a very much interconnected network. So there are a lot of sexual stimuli, the visual, olfactory, social cues, and the link with the emotions like fear, attraction, pleasure with the sexual behavior. And the nucleus accumbens, which is a part of limbic system, which mediates the pleasure, reinforcement, and the motivation for repeated sexual pleasure and activity. And the prefrontal cortex, which regulates the decision making, which has that impulse control and social inappropriateness. So these are the very important networking system which play an important role. And very interestingly, that during this developmental process, at this stage, there is always an underdevelopment in the adolescence, especially in the prefrontal cortex level. So that is why there is a lot of impulsivity in the adolescence, risk-taking behavior in the adolescence. Because if you look into the adolescence, the increased rate of death in the adolescence is mainly due to the risk-taking behavior, either in the form of accidents or trauma or injuries, mainly by their risk-taking behavior, in addition to the infections. So very importantly, there are a lot of emotional and contextual experiences, which is mainly by the immaturity or the maturation process, which is happening in this adolescent age. So that is a very important one in the sexual behavior, which we all should know. All the
Sorry to interrupt you, ma'am.
Another 5 minutes, we'll finish up. I'll finish up. So these are all the important roles in the adolescent which play an important role. So what is the clinical impact? We know pretty well in adulthood, the sexual behavior. We always look the adult in sexual behavior is viewed as a part of a healthy relationship. But in adolescence, the sexual behavior is often viewed from a risk perspective with focus on negative impact. So when you look into the conceptual behavior, what are the predictors and outcome? They have given the biological, genetical, familial, and social and the partner factors which play an important role for the outcomes. So all these things have an impact on the outcomes, which could be the sexual behavior or a sexual perceptions, and also their physical and mental and social health in relation to the adolescent behavior. So all these predictors, if they are in the positive way, definitely the sexual behavior will be in a better way. So the shape what we do for the teens is are first is the culture and the measurement bias. In our Rajasthan study, they have given The best friend technique is a very important technique that we have to adopt, especially in the family, the father and the son, or the mother and the daughter, or the sisters. If they have a best friend technique, which gives a very good positive way for their relationships difficulties, and even their help in the contraceptive use, which can prevent STI. So the population data in India, they say that the young men exhibit high risk behaviors, can be prevented by this type of a technique. So many of the psychosocial predictors have a role, which play a very important role in preventing this type of a behavioral changes, which plays a very important role in the adolescent sexuality. So to conclude, in developing countries like India, there are a lot of challenges, because we know pretty well that we have the highest number of adolescents in our country. So it is our responsibility to create an awareness where the adolescents are higher in number, with increased risk of getting early marriage, unplanned pregnancy, sexual abuse, as well as they have a lot of problem related to sexual behavior and risk. So we as a healthcare providers, in addition with the teachers and the teaching centers, we should create a responsibility to cater the needs of the adolescent sexual health, as they are very importantly play a role in a future country formation. So we should have a proper scientifically sound informed programs, which are the need of the hour, to educate them about the sexuality. So with this word, I thank you one and all for the patient listening, and I'm open to any questions. Thank you so much. Special thanks to ICOG for giving me this opportunity, and a very special thanks to all the adolescent committee people like Girish Mane sir, and for all your presence and blessings. Thank you.
Thank you,
Thank
Dr.
you,
Jain,
Jarani.
for the full presentation. Would the chairpersons quickly like to make closing comments, so then we can go to the next scientific session?
Thank you, Jairani. Sex is really difficult to define. It's natural and it is secret. And a lot of issues about adolescent sexuality, Indian adolescent sexuality is virtually towards the like a radical change. But we think that India has got a lot of positivity as well as related to Western countries, which is actually overshadowing their experience in the Google and in the social media. So there are many things to look into it. India is very different. That Rajasthan project was like something to learn, and our each state and each zone experience is different about adolescent sexuality. And I think that the adult world should present the healthy sexuality. This is one very important thing in society. The adolescent, they themselves, parents, and like a mother, father, and other gender relationship. So there are many insight to it, many very thought-provoking your deliberation, and it gives us a lot of things to work and to act. So thank you very much. Thank you, Durga, and all the conveners for giving me.
Thank you, madam, for your generous present.
Thank you so much, ma'am. And now we will move to the next session. And to chair these sessions, we will invite the chairpersons for the next session. We have Dr. Shashibala Sao, very popularly known as Pam, madam. Welcome, madam, for chairing this session. Madam is president of the Gwalior Menopause Society 2527. She has 38 years of dedicated clinical services, consultant gynac in public health and family welfare department.
Okay.
Welcome, ma'am. A big warm welcome to you.
Thank you.
We have Dr. Vidya Chaudhary. Dr. Vidya is MSFICOG, Professor OBGYN Department, Maharani Lakshmi Bai Medical College, Jhansi. And she has been awarded fellowship by ICOG and ICMH in 2013. Honorable Health Minister has awarded her with the maximum insertion of PPIUCD in Bundelkhand award. Very creditable. Welcome, madam.
Thank you. Thank you so much, Dr. Supriya.
And the next chairperson to chair this session is Dr. Jyoti Banglowala. Jyoti is the chairperson, Ethics and Medical Legal Committee, FOXY, 28 years of experience as an obstetrician, gynecologist, and medical legal advisor. Vice President, Indore OBGYN Society 22 to present, and Secretary of the Indore OBGYN Society 21-22. Welcome, Dr. Jyoti. Let us now move to the scientific session. We have Dr. Sanjay Kumar. I think this has come in the wrong time, is it?
Yes, we should have
fourth one,
Dr.
Fourth one, chairperson.
Fourth chairperson.
Okay. Okay, so we have the fourth chairperson with us, Dr. Sanjay Kishore Das. He is the consultant OBGYN Joint Director, Odisha Health Services, Joint Secretary, AOGO 2011 to 14, Joint Organizing Secretary, Yuva Foxy 2016, Vice President, AOGO and Organizing Secretary of Purvam 2016. Welcome, sir. We'll now move to the scientific session, and Dr. Basab has requested to go in second. So, Durga sir, will you please take up your talk?
Should I share my screen?
Sir, I will first request our chairpersons to introduce you. Welcome to all
Okay.
the chairpersons, and may I
Yes.
request the chairperson, Pam ma'am, can you please
Yes,
introduce
yes.
Share
Let
the
me have
screen.
this opportunity of introducing
Sure, ma'am.
Durga Shankar Dash sir. And thank you very much, ICOG and the conveners and the Parag sir, to give me this chance to chair a very important adolescent topic. And now let me introduce sir. Dr. Durga Shankar Dash sir is governing council member right now, and he has been in 2018 till 20. And he's a scientific committee chairperson, National Foxy ICOG Conference 2019. And he's been joint organizing secretary for AICOG 2018 Bhubaneswar. As past chairperson, Public Awareness Committee Foxy, core committee member, Foxy Cell on Sexual Violence 2013 to 15. And he's recipient of many awards, including Foxy Dr. Durusha Award. He's a Distinguished Community Service Award and Foxy and Dr. R.D. Pandit Research Prize. And after I had talked to him, and he has such a massive experience with the masses. So welcome, sir. We all would like to hear from you, your talk, your deliberation.
Thank you, ma'am, and over to you, Durga sir, for your presentation.
Please see, is my screen is shared?
Yes, sir, we can see it.
Not full.
Please just make it
Not full
slide,
screen.
slide
No,
show.
this is my plus side. I am just going to the second.
Okay.
Is it now
Yes, sir.
visible?
Absolutely, sir.
So, should I start?
Yeah.
Yes, sir.
Yes,
please.
yes.
Esteemed chairpersons and all the distinguished participants, you, the participants, have made our program great. So I am grateful, obliged to all the participants and the office bearers of ICOG. My topic today is sexual violence. Sexual violence, when we hear this term, we are horrified. We are horrified. May I remind you the incidents of last year when one of our lady doctor in Calcutta had to sacrifice her life at the hands of the criminals. So, to provide justice to our adolescents, we must be well versed with this course. Just see how much horrific the situation is. So, coming from the land of Lord Jagannath, I pray the Lord to bless us to develop the skill, the expertise, the knowledge, so as to empower us so that we can provide justice to the victims of adolescents. This program is adolescents violence. It can occur to a boy, it can occur to a girl. But primarily, we being the gynecologist, I will focus my discussions for sexual violence against women. Any behavior that is sexual in nature without a consent can be broadly told as sexual violence. But there are some definitions. Let us have a little bit knowledge of that. That any sexual act, attempt to obtain a sexual act, unwanted sexual comments or advances, or acts to traffic a woman's sexuality, usually coercion, threats, harm, or physical by any person, regardless of the relationship to the victim in any setting, including but not limited to home. So, a adolescent can be a victim of the family members and distant relatives, as well as authorities in office chair. So again, there's a cause of concern last year when the Argical College, Medical College, our lady doctor was rather, I will say, assassinated. What a deadly crime it was. The news came that only conviction rate is only 2.56% for rape cases in India. Just may I remind you, this is just the tip of the iceberg. So, according to WHO, the most vulnerable groups are adolescents. Further, if they are physically challenged or mentally challenged, if they are destitute, they are homeless, or under intoxication, either intoxicated or self intoxicated, they become further vulnerable to that. So, irrespective of the fact, whenever a such a patient comes to the hospital, such a victim comes to the hospital, it is always is a medical legal thing, irrespective of the fact that the victim does not want to intimate the police. Even if she doesn't want to intimate the police, it becomes medical legal. And any registered medical counsel, medical practitioner recognized by MCI is authorized to do that. We should remember that ignorance is no excuse, avoidance is injustice. So we must have to be well aware about the law and carry out our duties as per law and as per our um, um, responsibility. You see, what is the state of an affair when a young girl is sexually assaulted? I would like to remind you the statement of Laurie Halsey Anderson, a very eminent writer of America who was raped at the age of 13 years. I just want to sleep. A coma or amnesia would be better. I just want to get rid of this. These thoughts always whisper around my mind. Did he rape my head? That just imagine the trauma a victim of sexual assault comes across. Now, WHO defines some of the rights of the sexual survivor to be heard with empathy, to be believed. We should, whatever she says may be wrong, we have to believe it, to be treated with dignity, communicate in their own language. If required, an interpreter, might be hospital staff, might be a social worker, we can tell their help, be treated with sensitivity and understanding, be relevant and accurate about opinions, have considered confidentiality and privacy. My dear friends, this is of utmost importance that confidentiality and privacy must be maintained. So, what care a survivor need? We must be empathetic, urgent medical attention. We should help in swift trial, provide justice and psychological rehabilitation. So, we have seen the girl has arrived in our place in the hospital. We should provide her a suit, which should that suit should have 24 hours accessibility, should have security, lock, cleanliness. And yes, regarding security, I'll tell you, not that any hospital staff, whoever likes, can get entry at the time of examination. It should be absolutely comfortable, clean, there should be enough space, and waiting area for family members, social workers, and police. May I remind you all that police is not authorized to stand at this site of examination. Police can only enter as an attendant of that sexual assault victim whenever nobody is there with her and she gives her consent that police can be present there as in the attendant. Otherwise, police is not allowed to enter the examination room. Remember, we can allow also a pathologist friend to be present there, all sorts of equipments, responsible, and there must be a toilet that is very much required. This is the photo which says a comfortable room for the companions, family members, and this is the comfortable couch where the girl will be comfortable for examination. Safety of the victim comes first. Remember, if there are violent injuries, without delay, we must treat it. Then we should get a picture in our mind the moment the girls arrives at our place. What are the flow diagrams or waterfall diagram? We must have the imprinted in our mind. We should get the consent. Regarding consent, I am telling you, anything less than 18 years comes under POXO. That will be very vividly discussed by Dr. Dilip Walke. Subsequently, first aid will be provided. History, I'll come to that. Examination. In examination, we have to do age estimation if we are asked. Otherwise, it's not our responsibility. Evidence collection, treatment of injuries, evidence after that, evidence we have to thoroughly pack it, document it, and hand over to the police. Regarding treatment, we must provide treatment for injuries, prophylaxis for sexually transmitted infection, HIV, we must provide emergency contraception. That should be a thorough counseling and psychological rehabilitation. We can discharge the patient if treatment is completed, medical legal evidence is paraphernalia completed, and follow up the patient. Follow up is a must. So history, routine background, medical, gynecological, sexual, what had happened. We should not repeatedly ask the girl what has happened, and insist to say. We have to be tactful to get the history in an empathetic manner. Remember, these are the sites we must inspect. Physical examination, general examination, as well as genito-anal examination. From top to from head to toe, round the clock, around 360 degrees. Every parts we have to look into to note any injury anywhere. General appearance, upper arm, forearm, hands, face, ears, lips, scalp, neck, breast, abdomen, thighs and legs. These are sensitive areas. We must not omit. These are defensive injuries, signs of struggle. You have to look into that. You see, this is our abrasions on the back. The victim might have been dragged on the road or any surface. These are evidences. Again, these are injury marks of struggle. Non-genito-anal injuries. I told you what are the places, but just remember you have to attentively look. If there is a ligature mark anywhere around the wrist, around the ankle, these are helpful for forensic evidences. Now you have to see whether there is a bruising below the lip. These are fingertip marks, bruising on the upper arm. So, genito-anal examination. Remember, per vaginal examination is not allowed. Supreme Court has given clear directives that two-finger examination should not be done. That means two-finger examination is the PB examination. Any man, any doctor does that should be guilty of misconduct. Foxy recommendation, Foxy urges its members not to follow Government of India Health and Family Welfare Department guidelines for sexual assault examination and do not carry out two-finger examination. These are genito-anal injury, just gently separation of the labia and marked bruises around the hymen. Posterior faceti, that is the most important area to be marked. Here is a bruising in the hymen, and these are perianal bruising. Then forensic specimen, you must be very sure to collect. Vulval vaginal, so you can take swabs from the vulva, from the vagina. Vocal swabs, this is not mandatory, this is optional. You can keep it for DNA profiling. Fingernail clippings, pubic hair, if it is matted, semen contamination, you have to keep it, dry it and keep control pubic hair also for comparison. Clothings, if not washed. Toxicological samples, blood and urine, it is better always to keep it. So oral swabs can give you clue up to 1 day. Remember, drugs and alcohol in the blood can be detected up to 7 days. But remember, always store the urine because it can give you the clue up to 7 days. Rectal swabs also can give you for 3 days. Vaginal swab, if dried and sent properly packed, can give you information up to 7 days. So how will you take swab from the vagina? Just gently push it or take a vacuum syringe, attach a catheter to that, push normal saline and aspirate it and send that vacuum syringe along with the catheter directly to the laboratory for examination. We must have to provide emergency contraception. All of you know very well, 2 tablets of levonorgestrel given. If vomiting occurs within 3 hours, usually we take it 2 hours, but Government of India guidelines gives 3 hours. We can repeat it. If it is not available, combined oral contraceptives are available everywhere. We can give 2 tablets and repeat it after 12 hours. Remember, depending upon the situation, if it comes after 72 hours, you can think of the possibility of introducing a copper T. So post-exposure prophylaxis against STI, hepatitis B virus, HIV, and injury to the whole body. STI, if clinical signs are suggestive of sexually transmitted infection or diseases, collect the swabs. If no clinical signs, do not require it. Empirically, we can give prophylaxis azithromycin 1 gram along with 400 milligram twice daily of metronidazole. Alternatively, doxycycline 100 milligram twice daily for 7 days, but it is not given to the pregnant ladies. So for pregnant ladies, azithromycin and amoxicillin should be given. Metronidazole is not given in the first trimester. Hepatitis B, it is very important. If take the history of immunization, if she is immunized, we should not be worried. Otherwise, administer 0.06 ml per kg of hepatitis B immunoglobulin within 72 hours. Remember, you have also to keep a sample of hepatitis B examination of the victim. Now, post-exposure prophylaxis for HIV. It is always given within 72 hours. After 72 hours, it should not be given. And in which case you will give? If the assailant, if the assailant is untraceable, if the assailant can be a person who has got high risk behaviors, like truck drivers, like persons of indefinite origin, then post-exposure prophylaxis for HIV can be given, but you have to keep a sample of blood of the victim for testing of HIV. After that, you can administer a fixed dose combination of medicine, that is a combination of tenofovir, limobedin, and efavirenz. These are available in ICTC centers. So all these procedures should be preserved through safe kit, sexual assault forensic evidence kit, and a manual is also there. Read it thoroughly to carry out the procedure. So forensic evidence versus healthcare providers role.
Sorry to
Remember
interrupt you, sir.
that,
Your time is
yes,
up.
sir, I am completing within 30 seconds.
Okay, sir.
So factual evidence and expert evidence. We are absolutely non-judgmental. We are not the court. We are not the jurors. So we will give our expert independent view irrespective of the history given by the police. We will corroborate it, but we will be totally guided by our experience, expertise. So all of you, this is a picture where Ghar picture where Rekha was starring the main role. This is a rape trauma syndrome. All of you, please go through that and you can realize what sort of psychological trauma and sexual assault victim can undergo. With this, I come to an end. Again, appealing to Lord Jagannath to bless us with the power and expertise such that we'll be able to protect our adolescents and make them empowered to build a strong Mother India. Thank you.
Excellent, excellent, sir. Thank you so much. And you have really, sexual abuse has become so rampant. We must be well versed what you have done as soon as we examine a patient of sexual abuse. No PVs and all testing should be done. All this should be, everyone should know, because nowadays people are coming out and reporting sexual abuse. Nowadays, we should all know that. And PTSD will make another topic, sir, because that post-traumatic disorder needs to be like another topic. And yes, sir, you have done it so well and
We
all
have included it in the, madam, we have included in the panel discussion of mentor and mentee how
Okay,
to
okay.
take care of a sexual assault victim. I request all of you, please be there
Yes.
till that session.
Yes, yes, yes. It is very interesting. Thank you so much, sir. And I think you have such a good knowledge. This one session is not enough. So we'll look forward to
No,
another
madam, I
with
am
you.
learning. All of us should learn that we must know the
Yes.
procedure to provide justice to our victims. We must realize they are also our children.
Yes.
Had the situation occur to my daughter, we should think like that.
It can happen to anyone. Yeah, and we cannot depend on the police or anybody to help us. We have to be self-reliant when we are faced with this danger. Thank you so much, sir. And if anyone else wants to say something, Vidya, Dr. Vidya,
Yeah, ma'am.
would you like to
Thank
comment?
you. Sir is excellent. Sir, talk is very excellent. Sir is the, I think,
Thank you,
master of
Vidya. Thank you, Vidya.
sexology. Thank you so much. Thank you so much, sir.
So, Vidya, I'll
Or
request
you
that
have
let
told
all the
already, we will
speakers
discuss. Yes, yes, sir.
let the speakers be limit to time, maximum 1 or 2
Yes.
minutes, not more
Ji,
than
ji,
that.
ji. Yes, yes.
Okay.
Thank you so
Okay,
much.
let us proceed to the next speaker.
Yeah, thank you.
May I request Madam Chairpersons Vidya ma'am, will you please introduce Dr. Basab Mukherjee
who is the
Sure,
speaker,
sure,
next
sure.
speaker for the day.
Dr. Dilip
Good evening, sir.
Welcome, Parag.
Yeah, Dr. Dilip wanted to go early. If you can just check with him. Yes, Dr. Dilip wanted to go early. I'll go after Dr. Dilip. Huh? Thank you. Thank you.
Okay, Dr. Dilip, are you there, sir?
Yeah,
Ready?
I'm there. I'm there.
Okay, then, madam, please introduce Dr. Dilip Varke
Okay,
and we'll have
okay.
Master's talk first.
Okay, very good evening to all of you, all the seniors and and colleagues. Next talk is by Dr. Dilip Vake. He is ex-chairman Ethics of Medical Legal Committee FOXI in 2007 to 2010. He is also ex-president Pune Obs and Gynae Society in 2019 and 20. He is co-author of Uniform FOXI Consents and the director Osphere ART Private Limited. Welcome, sir. The screen is yours.
Thank you. Thank you so much. Can I share my screen?
Yes, sir. Yes, sure.
So am I audible and is my screen seen?
Yeah, sir. Screen is visible. We'll make it full screen. That's it.
Okay. Thank you very much
Yes.
for that short introduction. And thanks to ICOG and Parag for giving me this opportunity. Parag had warned me that you have only 15 minutes. So there will be no legal jargons. Simple language is what is expected. And I'm supposed to give only the gynecologist perspective when it comes to POXO Act. When it comes to gynecologist perspective for the POXO Act, we will talk only about girls and not about boys. But you have to understand that POXO is basically gender neutral. So POXO also includes boys less than 18 years of age. And what from POXO point of view, what we have to understand is that as gynecologists, we have to give medical care in terms of contraception, abortion, pregnancy care, and all the treatment as was discussed about sexual assault. We have to know about mandatory reporting. We have to know about medical examination and the law regarding that, the consent issues, the confidentiality issues, and all the overlaps with other acts like MTP, PCP, NDT, and the Juvenile Justice Act. So we have to understand all this, and we will keep writ petitions and advocacy out of scope of today's presentation. We will only stick to what the law says about these points that I have mentioned in the slide. So now, though Parag told me no legal jargons, a knowledge of some sections is essential for us. And that's the reason why when it comes to mandatory reporting, we have to understand section 19. And I will have stressed upon those points which are important. Any person, they say any person, not just gynecologists, it can be radiologists, it can be your staff nurse, your Aya, your Metrani, anybody on the earth who's having a knowledge of contravention or who's apprehensive that there is a likelihood of contravention, which contravention has been done or is likely to be done, and they are supposed to report it to the local police or the special juvenile police unit. And if they don't do it, the section 21 says that there can be an imprisonment of maximum 6 months and fine or both. So this is what you have to understand, that everybody and anybody who has come to know about the act or who is apprehensive that this act has been conducted or there is a possibility of such a contravention, they have to report it. Then examination. Number one, you have to understand legally how is it that the examination has been is to be done. There was a wonderful talk on that, but the talk tells us that the exam from legal point of view, it says that examination procedure as per the CRPC 164A is same as the examination of a rape victim. Who does the examination? The act is preferably a woman doctor, but that does not mean that if a patient comes to a male doctor, the male doctor can refuse to examine. If the girl child is ready to get examined by the male doctor, then with her permission, even a male can examine. And with whom? Ideally with the parents. If not the parent, then anybody whom the child has trust and confidence, which means if any bystander has brought the child to you, and if the bystander says that I want to be present while the child is being examined, and the child says yes, I don't mind being examined when the bystander is standing there, then you have to allow that person. Or then in that case, if there is nobody, in that case it is some female attendant which has to be nominated by the institute. Now so which means rapid fire, male doctor takes child's express consent and he can examine. Lady who has brought the child wants to be present while the child is being examined, you cannot refuse it. Then about confidentiality. About confidentiality, the act says that media shall not disclose the identity of the child, the name, the address, the photograph, the family details, the school neighborhood, unless it is allowed by a competent authority in writing in interest of the child. So unless there is something in writing by the court, the media cannot disclose the identity of the child. So you will realize that whenever media talks about this child, they will not tell the name, they will have a different name. Punishment to the owner of the media in case that is done is 6 months to 1 year of fine or both. But what about doctors? Can police insist that doctors have to disclose the identity of this minor while they are treating? Now we'll discuss it in the writ that Dr. Nikhil Datar just did last month. So we'll know about this a little later. I'll park this question for the later slide. Next question: is consensual sex in couples less than 18 years considered to be rape? Unfortunately, this legal answer to this is yes, it is considered to be a rape. So a 15-year-old girl with a 17-year-old boy and all other things, a permutation and combination of both being less than 18 years of age, they are considered to be having performed got involved into rape. And now how to decriminalize both of them is a solution is in a writ, and about which I can talk to you a little later. And but advocacy is needed to change these points in the POXO Act. Some real life and hypothetical cases to learn from. Uh, uh, can you refuse to examine a case of sexual assault and send her to a government hospital, saying that get the police FIR or get the magistrate inquire first and then only I'll examine you? The answer is no, you cannot do that even in a private setup, as per the CRPC 357C, which says hospital, even private, have to examine, treat, and inform any rape victim. Leave aside anything, any rape victim less than 18 years, but any rape victim, any victim of sexual assault, the hospital has to examine and treat and inform the police. And in case of POXO, the section 27 says that there is no need for a police FIR or police requisition for you to examine the patient. And the rule 5 says that there is no need for a magistrate order before you examine the patient. So don't waste that golden hour time of collecting all the evidences when the patient comes to you for examination. Now, a little bit about those girls who are victims of this sexual assault who are more than 12 years but less than 18 years of age. Have a look at this situation where the girl is more than 12 years but less than 18 years. She's got a history of intercourse and she fears that she could be pregnant, but she tells you, please do not tell my parents. Now, what do we do? Can you say that I will not tell the parents, or should you enforce and say, no, 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 I'm going to tell your parents about it? The answer is whether to inform police. Yes, the answer definitely is yes. But whether to inform the parents, since more than 12 years patient can consent to a non-invasive examination. I mean, when it comes to invasive thing like a medical termination of pregnancy, then you have to take consent of the legal heir. But for examination, for non-invasive examination, if she is more than 12 years of age, she has got a right to give the consent. So she has got a right to hide it from her parents also. So we can counsel. Can we counsel about the contraception and safe sex is another question that many people ask me. The answer is educating anybody who's less than 18 years about sex, about contraception or safe sex does not amount to encouraging sex. But do not give personal prescription to the girl about the different methodology of contraception. So you can definitely educate this girl about contraception and about safe sex. That is not illegal, and that will not amount to you encouraging her to get involved in sex, which is considered to be illegal if she's less than 18 years of age. Again, girl child less than 18, more than 12 with pregnancy. Now, child does not give consent for a non-invasive examination. Do not examine this patient because she's more than 12 years, but you have to inform the police. Child is willing, but the parents are not giving consent for surgical MTP. In that case, what you can do is inform the child welfare committee through police, and non-examining examination. The child, if less than more than 12 years, child has to give a consent for a non-invasive examination. For an invasive procedure like MTP, legal guardian as per the IPC 87, 89, 90 and relevant acts of the BNS are the ones who will give you consent for any invasive procedure. So these 2 points that I have told you, you have to understand when it comes to a child between 12 years and 18 years of age. Now again, less than 18 years, surgical MTP done with parents' consent and the police is informed. So this part of it you have done. Parents wants to send the product of DNA, product for a DNA testing, and the parents say that we have given consent for MTP, so we have the right to say what to do and what not to do with the product. But the girl says that I do not want to implicate my boyfriend. I gave you consent for non-invasive examination, so I have a right over the non-invasive test. So this can be a legal kind of a question that can come to you in front of you if the parents are insisting that the products have to be sent for DNA testing because they want to know who's the one who made their daughter pregnant, but the girl does not want to implicate the boy, and girl saying no, you didn't send this sample for DNA testing. The popular answer is if she is more than 12 years of age, it is her right to decide whether to send the products for DNA testing or not. But there are other legal experts who say the partner has committed a non-bailable crime under the POCSO Act, so she cannot deny the inquiry. So again, the legal people have got a different opinion on this. I would say that you take a consent of the girl and only then send this sample for a DNA analysis. Unless you have something written from the girl, do not send this sample, so that otherwise you will get involved in some legal tangle. Again, less than 18 years of age for MTP, police informed, MTP done before the police arrived. So you did not even wait for the police to come to do their inquiry, and you did perform the MTP. And the police would then say you should have waited for us. Answer is there is no need to wait for the police. Inform the police that MTP is planned on this date at this time and ask them to come and collect the sample for DNA as soon as possible. As tell them that you do not have facility to further store the products of conception for DNA testing. So it is their responsibility to come and collect the sample. Now, if there is a girl who's more than 18 years, which is she's 18 years and 4 months pregnant with a full-term pregnancy, this also you need to inform the police, because when she got herself involved in the sexual activity, she was less than 18 years of age, because now she is full term, which may only mean that when she actually conceived, she was less than 18 years. So this also you have to inform the police. Now, another question that many a times people ask me, I say I am practicing in a village, and if I call local police or the relatives can harass me, how should I protect myself? Because it is very easy for us who are practicing in metropolitan cities to say that inform police, because everything is easy for us here. But if somebody is practicing in a village, and if he informs the police and the relatives start harassing him or her, then it becomes a problem. Then how to protect? The jugaad is inform the police on an email. Tell them, send them an email that I am at this moment treating a patient of sexual assault, who's less than 18 years of age. I have preserved the DNA sample. Please, send someone to collect the sample and do the inquiry. So at least you will have something in the court of law to prove that you had informed the police. 16 years old girl brought by mother with urinary tract infection, and you detected bruises on the groin area. And the mother says she fell while cycling. But you suspected sexual abuse, and this time you are suspecting that the abuse was done by some near relative, because the mother is trying to protect this person who did the abuse. So you informed the police, and later on in the court it was found that there was no abuse, no sexual abuse. Now, do the relatives have a right to put a case against you because you made a false claim? The answer is no, because you did it in good faith and you will not be held liable for it. Is that the sign that my time is up? This music, is it telling me that my time is up?
Yes, sir.
Yes, sir.
Yeah. So I think there were some googly questions. I think the googlies we can keep for other time. If there are any questions, I will take them. Right. So that's all. Thank you very much. I rest my case here.
Oh, thank you so much, sir, for such an excellent, very well elaborated, legally elaborated POCSO Act, and with a very well explained the common scenarios we are facing day to day. I think it is excellent talk, sir. Googly, I think the time is short. We will see
Googlies,
next.
we can people can personally ask me, and all these googlies.
Yeah. Yes, sir. Share your slide. It was excellent, sir.
Yeah.
Very
I'll share
good.
my slides with everybody. So if there
I
are
will
any
like
Yeah,
to have a
sir.
recording also of you.
Yeah, sir. It was very good slides.
This
the
is
slides
child
are all
under 12,
yours.
under 18. Yeah.
Excellent, excellent, sir.
Yes. All pros and cons you have considered.
Yeah.
Yeah.
Thank you very much. Thank you so much.
Thank you. Supriya,
Dr. Jyoti
Can
hai?
I-
Dr. Jyoti is here.
shall I
Or
introduce
we-
Dr. Basa?
Hello. Yes, ma'am. Sorry, my internet is little unstable. Yeah.
Yes.
Please go ahead and
I'll introduce Dr. Basa. My
Yes.
my
Please do,
luck,
ma'am.
Dr. Basa Mukherjee needs no intro as such. He's Director Ankuran Fertility Fetal Medicine Center, and he's got organization roles. He has been VP Foxy, and he's at present Bengal OB-GYN Society President, and he's been Vice President Foxy. He's been member FIGO Safe Abortion Committee. He has been chair of IRC India East. He's right now chair, and 2024 to 27, and he's secretary IG Bengal chapter. And he's got lots of awards, lots of achievements. Yuva Foxy Kaminira Orator, a FOG Young Gynecologist Awardee, and DC Datta Best Publication. And I think I cannot see as secretary box for 4 years National Foxy Awards. So, Dr. Basa, we are eager to hear your on contraception. And
Thank you.
over to you.
Thank you, ma'am. Thank you very much. Thank you to the ICOG team on behalf, and after two wonderful talks by Dr. Durga and Dr. Dilip Walke, I think this will be a little less interesting in that way. It's called adolescent contraception, but nevertheless something which is important. I'll just share my slides in a second. Yeah, just here I am. Thank you. So over the next 10 to 12 minutes, we take you through a journey of adolescent contraception, not something which you do not know, but something which possibly will help in some sensitization to all the participants and all the people who are attending this. So stating the facts which we know about adolescent contraception, by the age of 20 years, it is said that nearly 80% of all women have sexual intercourse in Western countries. The figure may not be very different in our country, but we do not have figures for everything. A lot of them are married in our country before 20, and that's be one chunk, but the unmarried adolescents also would form another section. They have, unfortunately, the lowest level of contraception knowledge and use, and they have a higher risk of unwanted pregnancy, unsafe abortions, and STIs. And that is the reason why this seminar, designed by ICOG under the leadership of Dr. Parag and by the wonderful conveners, is so important for everybody to attend and to take care of. So unwanted pregnancy, unsafe abortion, sexually transmitted infections, these are some things which is absolutely a no-no for any age, especially adolescents. And actually the problem of the matter is that they don't think about these when they're having intercourse. Many do not use any contraception at all or use a method inconsistently. The commonest ones we know which are used are barrier as a condom and emergency contraception pills as pills. Nobody uses much in anything different by themselves. So adolescent pregnancies make up around 11% of all births, and that is a problem. So this is some studies from not very long ago, where there was reviews done in 12 low and middle income countries, and they showed 8 million of the 9.5 million unintended pregnancies occurring annually in 12 countries could have been prevented with the optimal use of modern methods of contraception. So modern methods of contraception, though we keep on talking about it, which would also include oral contraceptive pills and IUDs and long-acting reversible contraception, still remains pathetically low used when it comes to individuals, especially in the adolescent age group. Either it's because they do not come to a medical doctor to take some advice, or they do go things on their own, or they have internet advice or ill-advised, or they do not use methods consistently. And this is also one of the things which you say, that there are 15 million women in the late adolescent age group of 15 to 19 have an unmet need, and large gaps remain in meeting family planning needs in adolescence. And this is something which all of us as healthcare providers first and are important, that we all do our little bit to plug in those gaps and make sure that women get the contraception that they need and that they have. It is understood that we had a wonderful talk from Dr. Dilip just now. We have to work under the legal and ethical framework of the country. So practitioners may wish to inform a young person of the law of the land in relation to sexual activity, and POXO comes into the picture, which fixes consent at India 18 years for boys and girls. And that is something which is so important that we bring this up and discuss about it, because you are supposed to report, as Dr. Dilip said, and Dr. Durga had also brought this up in his talk on sexual violence. There's no shortcuts about POXO Act. You know the act, but sometimes they say you bring in a lot of common sense into it. But even common sense or no common sense, you would have to do what the law of the land says. It's not about protecting anybody, it's about protecting yourself and doing the right thing. Healthcare professionals may use checklists. There are checklists in the UK which were used even decades ago, that the Fraser guidelines are to assess the competence of a person who's coming and asking about a contraception, how informed or ill-informed he or she is, and that would be important. But the important thing also, the word important here is confidentiality, and I think that is so important when we talk about adolescent contraception, or even taking care of adolescents in general, which has great challenges, especially in our public sectors where there's a very busy OPD. How you maintain confidentiality of an adolescent there is really a challenge, and it's a little easier in the private sector, but still a lot of us also have our own biases and our own opinions, which should not come into the way ideally. So contraceptive options for young people should be informed of all methods of contraception, highlighting the benefits of LARCs. And long-acting reversible contraception, according to many public health specialists, is the way forward for adolescents. So it is not something like a lot of people said that you reserve it for the last, you start with something else. Not necessarily. You can start with an IUCD in an unmarried adolescent. You can start like injectables if that is what her choice is. If she's around later into the adolescent age group, age should not limit your contraception choices, including intrauterine methods. And that is something which all of us know, but preferably we don't use. But again, this discussion should be taken openly to the client, to the woman herself. And then if she really thinks that this is in her best interest, she can adopt methods with the checks and balances which we would have. So young women should be made aware of the different types of emergency contraception available. So the emergency contraception, people would have patchy knowledge at the most. People would go by what they see in advertisements, and that information would not be fully correct. So when a woman is spoken about regular contraception to be used, the issue of emergency contraception should always be brought in. You do not assume that she doesn't know about it. Of course she knows about it, but sometimes she may not be talking to you about it, but you have a chance to talk to her about it and to discuss this, and that should be openly discussed in a clinic. So addressing young people's health concerns and risks. So what are the risks or what are the concerns? Weight gain is the number one concern with any hormonal contraception. But except for DMPA, which there is some suggestion of weight gain with prolonged use, there's no evidence for combined hormonal contraception in any form, oral patches or rings or anything. And the acne, we know there are combined oral contraceptives which can improve acne. Almost all of them can, but the one with the more androgenic ones can do better, like the one with cyproterone or drospirenone. Delay in return to fertility, yes, but none except DMPA, which we know, and that is of a concern, which we can talk to people who may carry that concern. Bleeding patterns and dysmenorrhea. Unscheduled bleeding is characteristic with many hormonal contraception, especially progesterone only. So that discussion and that counseling should be happening very early as you prescribe that medication. And again, it doesn't happen to everybody universally, but it can be taken care of, and mostly it settles with time. And she should be have an emergency number or a contact details of somewhere to go if she has a problem and she needs to get which gets sorting out. And COCP combined hormonal contraceptions may improve primary dysmenorrhea. A lot of people are concerned sometimes about the less amount of bleeding which happens with contraceptive pills rather than the irregular or the unscheduled bleeding. So a lot of people have to be told that you're having less bleeding because you are having less amount of endometrial thickness, and not because the periods will go or the blood is getting stored somewhere, or you will have a tumor at some point of time. Those are some wrong messages or wrong myths which people deal with. About bone health, yes, we know that apart from DMPA, which has some reversible bone loss, there's nothing else to suggest anything else should be restricted under 18. About cancers, yes, we know that during the prolonged use of common oral contraceptive pills, there may be a small increased risk of CA breast, but no, but generally you have a much persistent reduction in ovarian cancer, and colorectal cancer is definitely there. STIs in young people, well, the correct use of condoms to reduce STI risk is something which should be over exaggerated, because we do go to colleges. Now, the biggest thing is to talk about cervical cancer vaccines, which all of us in our different capacities do go and visit schools, colleges, and the Rotary clubs and different sort of forums. And there, I think, besides if it's an adolescent population, I think contraception also has some sort of a role to talk about, and the MTP. Sometimes it may be a little uncomfortable among your seniors or the parents of the same people, but it is the truth. Especially in a closed door environment like a college or a high school, it definitely has to come up in some part of the discussion of reproductive health. Or you can give them they can write chits and they can write down their queries. Out of 10 queries, 7 come up with sexual problems which children may have, at the late adolescent age, especially. STI screening, if there was unprotected sexual intercourse and you know when to screen for STIs, is generally after 2 weeks and 12 weeks. But the quick start method is the method which would be preferable for most of the contraceptives in an adolescent. Waiting for a menstrual cycle to clear to start contraception, which is the normal thing which a lot of us do, is not something which is in the best interest, because she may be lost to follow-up, or she may get pregnant before she actually starts the contraception. It has less unintended pregnancies, improved short-term compliance, and less breakthrough bleeding. So the follow-up criteria is for follow-up is to follow criteria to be reasonably sure that she's not pregnant at that time when you started. We'll just bring up that criteria in the next slide. Otherwise, you do a urine for pregnancy test and follow up in 2 to 4 weeks with another test. But it is understood that even if she is pregnant and she takes medicines by accident, there is nothing to show that that causes any harmful effect. So how would you know a patient is not pregnant already? Of course, if it's less than 7 days at the start of menstruation and she doesn't have intercourse in that time, and she is already using a reliable method of contraception, or less than 7 days after an abortion, or 4 weeks after a delivery, or she's exclusively breastfeeding amenorrheic, less than 6% per 6 months of postpartum, where she's completely lactation amenorrhea is still persisting, then it's a very less chance of having a pregnancy. The important thing again comes to counseling, and I think that's where all of us need to play a part. It's important to establish a rapport, and that doesn't come easily, and that doesn't come in a very busy OPD where you have just hardly 2 to 3 minutes to dedicate to each patient. But it is important to do so, especially in an adolescent setup, and to ensure confidentiality. Otherwise, you will lose that patient forever. Not about you losing, she will lose confidence in you, and she may go to a less qualified person and have more serious consequences if she misses out on your visits. Address her contraceptive needs, expectations, and concerns. Address common misconceptions, misperceptions appropriate to her health literacy. That's important. You understand what her health literacy is, how much do they understand, and that is something which will be important to guide your discussion on where to start from, and how much of information to give. A lot of information dumping may not always be good. A lot of us love to give information and love to speak and speak and speak and speak, so that may not be in their best interest. So information dumping is not a good idea. Emergency contraception access must be brought to right to refusal. Even after saying everything, she may say, no, doctor, I don't want, and then you have to respect that. No coercion, you can't force her. No moral policing. Hey, sex is bad premarital. Hey, you guys should be studying. This is not the right time to have sex. That's not, those things are changed. Then the gathered approach, we all know that: greet, ask, tell, help, explain, and return for further advice and counseling. Short of time, but we know the gather approach. We have heard of it from our MBBS days, and it still holds true. So addressing barriers, there's several barriers here. You have to look at the laws, whether the POXO, whether you can do anything with it. Talk to the legal people, talk to the politicians, and that's something as a lobbying, and that's a larger part of it. Building community support for provision of contraception to adolescents. Understand the importance. Sexuality education. Make sure that the teachers in the college and school understand what it's all about. Try to increase access to adolescents. They often know that they have to use something but don't know where to get it from, or don't know whom to get advice. Contraception through various outlets like a lot of NGOs do, and a lot of use of the mobile phone, social media to have a help in promotion. So the takeaways from this: adolescent contraception will always be a challenge. Awareness of fertility potential. Yes, you can get pregnant from one single intercourse. Proper sexual health education. Consequences of STI, unintended pregnancy, should all be highlighted. And the awareness among healthcare providers for counseling adolescents without bias, legal and ethical consequences, as very nicely pointed out by Dr. Dilip in the previous talk, must be kept in mind. Thank you very much. Thank you.
Thank you, Dr. Basu. The contraception, you made it so interesting. Yeah, and you phrased it so well. Counseling, rapport, confidentiality. So all these things matter. As soon as the patient comes, we start moral policing. And so that's how we lose the rapport. And everything you have reversible, all about IUCDs, you have emergency contraceptive and quick start. You covered everything and gather approach. So you have left nothing. And of course, we'll have your recording also so that we can share with all these things. And thank you so much. And it was excellent, excellent. Thank you.
Thank you. Nice to
so
see
much,
Dr.
ma'am.
Supriya.
Yeah,
Supriya, congratulations. And we look forward to great things
Thank
from
you. Thank you
throughout
so
your
much,
tenure.
Basa. I'm really
You've got
looking
Girish to
forward
guide
to
you.
work.
You've got other people to guide you. Dr. Bharti is here. Durga is here. Durga is doing a great job. Dr. Vidya. I'm seeing the people who have their videos on and all the rest. And Pam, thank you for.
Hello, Dr. Basar.
Thank you so much.
Okay.
Let's
Thank you,
proceed with
Basav.
the final talk for this session, and that is by Dr. Bharti Maheshwari.
Bharti has arrived.
Vidya ma'am, are you around? Then will you please introduce Bharti ma'am to our audience? Vidya ma'am?
I think I'm the only permanent chairperson here.
Yeah, actually she's logged in, but I guess.
No, I would love to introduce
Vidya ma'am is
Bharti.
here. Vidya ma'am, please proceed with introducing Bharti, Dr. Bharti Maheshwari.
मैडम आप कर दीजिए, मेरा वो फोन आ गया था तो वो हो गया था.
ठीक है.
Should I share my slides?
हाँ मैडम.
No, first
introduction.
introduction.
My CV, she can introduce by that. No issue.
Yeah.
Okay.
Yes, ma'am.
I will
Okay, welcome ma'am. Welcome Dr. Bharti Maheshwari ma'am. She is professor at present and the head of the department of Muzaffarnagar Medical College. Everybody knows, I think, Dr. Bharti also. She needs no introduction. She is head and she is also DIP diploma in IVF and reproductive medicine from the Germany. She has she did her fellowship in medical education by MCI FIME. She served the Foxy as the chairperson for the MTP committee in 2018 to 2020. She is governing council member ICOG, secretary of the at present secretary also of UPCOG, president Meerut OBGYN Society, also president of Meerut ISOPAB and Meerut Menopause Society. She is chairperson ISOPAB Family Welfare and Reproductive Medicine Committee. She is author and editor of so many textbooks of OBGYN.
Thank you, Dr. Vidya.
Has
I
published
think
so many
we should
papers
utilize
and
time.
okay, ma'am.
Yeah.
Okay, welcome, madam. Screen is yours.
So thank you very much to whole ICOG team as well as Dr. Parag Viniwale and all organizer of this particular certificate course. As we all know that they have given me opportunity and have chosen very good topics, and we all are seeing that how successful this certificate course is going on. So I have to talk in next 12 minutes about MTP in adolescents. So we all know that still every day 13 women die in India due to unsafe abortions and its related causes. And WHO carry message that prevent unsafe abortion through comprehensive sexuality education, access to affordable contraception, as well as safe abortion care. Here I want to state the WHO statement, another statement. What here it says that regarding safe abortion, respect for women's informed and voluntary decision making, autonomy, confidentiality, and privacy with attention to adolescent and women with special needs. So that's why, and not only this, access to safe abortion depends not only on the availability of services, but also on the manner how it is delivered and the treatment of women within the clinical context. Services should be delivered in a way that respect a woman's dignity, guarantee her right to privacy, and is sensitive to her need and perspectives. Attention should be given to special need of the poor adolescents and other vulnerable and marginalized women. So what are government of India, and they have made a policies that we have to devote adequate time for the counseling, maintain privacy and confidentiality, use safe technologies like MVA, EVA and MMA, follow standards protocol for infection prevention, pain management and complications management, offer post-abortion contraception services, provide reproductive and other health services, RTI, STI, counseling on sexual violence, and services tailored to a woman's medical and personal need. And as we all know that MTP is not only medical issues, it has lots of social policies, economical and physical access. They all are its influencing factors. So keeping in this all mind, we all know that there are lots of challenges in providing MTP services. And one important data or fact is that still awareness of legacy of abortion in India, it is less than 10%. And in the very important studies, it is found that around 78% of girls or women, they have taken with self-medicated MTP pills and having the excessive bleeding. So still we have lots of issues regarding MTP, and we are also concerned about the litigations regarding MTP. So all what we need to know, that is proper counseling, documentations, improving skills, and most important, know about the MTP Act. So whenever we talk about either MTP in adolescents or any women group, MTP Act Amendment 2021, we all should be familiar. That is with a view to increase upper gestation limit for termination of pregnancy under certain conditions. And this is, you can have to know or to improve your knowledge or to update you. You have ICOG campus that is available on the Foxy website sites regarding the clinical implementation of MTP Act 2021 as well as MTP Foxy Focus. And you can have all issues from MTP 1 to last in these particular documents. Besides that, you can have Government of India's documents like Comprehensive Abortion Care 2023 as well as ensuring access to safe abortion and addressing gender bias sex selection. You can go through. So when we talk about the abortion in adolescence, we have to take care of what is the clinical issues as well as legal and social issues. So whenever we concern about the clinical issues of MTP, always we have to take care of, we have to fulfill all components of comprehensive abortion care, like start from counseling and obtaining voluntary informed consent, clinical assessment, pain management, uterine evacuation, managing complications, post-abortion counseling and follow-up, and post-abortion contraceptions. So when we, what should be the actually approach when any adolescent comes to you, either with parents or guardians to you, always you have to we have to taken care of respectful care, and we have to maintain the privacy, I have already told. And then we have to check the indications, we have to confirm the pregnancy, identify indication of MTP, and then we have to see all legal issues, especially we are talking about adolescent. And then we have to always obtain informed consent on the Form C, do the procedures, and maintains all documentation as it is advised. You can get all these things on the different states' websites, what forms you have to fill. And in this manner, this is a picture of websites of the UP and the National Health Missions and from the different states. Then once an adolescent come, I have already told that you have to check the legal eligibility, rule out or high risk factors, check facility at your place, check providers eligibility, as well as then do selection of method, counseling of women and informed consent. Indications, always we have to check. These are the different indications. We all are familiar of that. So what there is amendment has been done in the 2021 only, that pregnancy was caused due to failure of contraception in women. So that has to be taken care. And we'll talk. And in the counseling, either adolescents, so we have to taken care that adolescent is group like mainly 10 to 19 years. If we are taking then less than 18 years, we will apply the POXO Act. But above 18 years, you have to do all counselings and all provide all services as you do in all women. But here the message is that do not refuse MTP if she's not accepting contraceptive method. You provide her services, but and continue to follow for the contraception. Ultrasound examination, we all know it has a role and we should do, but though as per the MTP Act, it is not mandatory. But definitely it is useful when we are doing the MTP in adolescent. Now come any girl, which she's adolescent, like 16 years, 17 years, 15 years, come with guardian mother that she having the 8-week pregnancy and she needs termination. She doesn't want any legal interference. Then what you have to do? So of course, the POXO, it comes when there is a minor girl. It's not married or unmarried, but there is a minor girl. Then definitely you have to inform the police about the procedure and about the case. Not that you have to not you have to file FIR, but only you have to provide the information to the police about the case and clinical procedure you have to done, and counseling about the pre and post procedures and with proper pain management. POXO Act, I think already always it is told, so we all know that what is the POXO. I'm not going in the detail, but we all should know that medical practitioner must remember that while completing the reporting formalities under the POXO, it is also important to ensure that services are offered to the client and all documentation is maintained as per provision of law. And the medical practitioners are not obligated to file an FIR or conduct an investigation. The provider's duty is to only inform the authorities when providing services to a minor, including abortion services under the existing provision of MTP Act. So counseling about girls always, whenever you have done formalities and you have to do MTPs, then you have to tell about the all available options for MTP, associated risk, associated care, and contraceptions about the after this procedure. And then you have to check the associated. You should have checklists so that you can find out whether she's any associated anemia or ectopic suspected and diagnosed adnexal mass, hypertension, heart problems, and renal, liver, any medicine histories, and these things you have to fill. And you have to check that whether your facility is having the Form B, whether you are allowed to do MTP, and as well as consent. If she is minor, then I have already told you that she can, any guardian can give consent, adult guardian, and it means a caretaker willing to be responsible for the woman. And then Form C, always consent has to be taken on this form. Form 1 opinion form has to be filled, and the signs of the two RMP has to be done if it is more than 20 weeks. And then always you should know that according to MTP Act 2002, when enhancing the upper gestation limit from 20 to 24 weeks in survivor of rape, victim of incest, and differently abled women and minors, as well as then Form E and Form D, you all should know. And in the beyond 24 weeks, you have to need to support of medical board, and this is the Form D, which has to be filled after 24 weeks of termination of pregnancy in adolescent or any other woman. And this admission register has to be filled in all cases. And admission register is confidential documents, and confidentiality and privacy is given lots of emphasis in MTP Act 2021. So you have to take care of all these things, and mandatory documentation you have to fill. So this is the important legal issues what you have to do with the MTP in the adolescent girl. Now come to the options for the clinical method. Of course, in the first trimester you can offer medical or you can do the MVA. I always request all of you that please train your staff and your colleagues in the MVAs, medical methods, provider eligibility. All of you can, or registered medical practitioners can give it from your OPD if your OPD have the established linkage to an approved site. And documentation for the medical method abortion, all forms you have to fill as in the surgical method. And other type of abortion, like if woman already had taken the, or girls already had taken the pills and comes to you, you are not need to fill all forms. It comes under the missed abortion or incomplete abortion, so they are not under the MTP Act. And this is the whole checklist where you can find out when you give the medical method of termination. On the first visit, what you have to do, important thing is that is real history, counseling, examination, contraception options at the same first visit, investigation, anti-D if RH negative, and very important thing is that give contact address and phone number of the facility where women can go in case of emergency. And on the third day, when you give misoprostol, then observe the woman for 4 to 6 hours in the clinic. And in the 15th day, when you call her, ultrasound is not mandatory if you are clinically insured. And again, you have to call the woman if she has no period within the 6 weeks. And this is very important follow-up card. All of you should give to your women. These all things what I am telling you are by the National Health Missions or government's guidelines. And if woman is having excessive bleeding after giving medical methods, you all should know that if her vital signs stable, you can check that clinically. If you found the product of conception, evacuate, or otherwise you can do the ultrasonography. If non-viable gestation sac additional dose, you can give 600 microgram misoprostol and follow after 7 days. And if there is a viable sac, then vacuum aspiration has to be done. And the nulliparous cervix, because adolescent, the issue is that it is nulliparous cervix. If it's there, then of course cervical preparation is very, very important. Tablet misoprostol 400 microgram 3 hours prior to procedure. And if required, an additional 1 dose 200 microgram can be placed in vagina. Alternate to misoprostol, you can use the PGE2 or subprime catheter balloon or PGF2 alpha if it is not successful, but I found the misoprostol very good. Syntocin infusion additionally in the distant cases or hysterectomy consent required. And beside that, I already have known that everyone should be familiar with the medical manual vacuum aspiration. So these 10 steps everyone should know that how to prepare the syringe and how to use the cervical antiseptic preparations, administer paracervical block, dilate cervix, insert cannula, suction, inspect tissue, concurrent procedures, instrument processing. Administer a paracervical block. Everyone should learn it that use lignocaine 1% 10 ml and give the paracervical block using 22 to 24 gauge needle and apply slight traction and with the ball saline to the identified area between the smooth cervical epithelium and vaginal tissue. Insert the needle just under the epithelium to a depth of 2 cm at 4 and 8 o'clock position and inject 2 to 4 ml of lignocaine side paracervical block. And believe me, it is very effective and proceed with MV after allowing 2 to 4 minutes for the local anesthesia to be effective. Sterilization of MVA equipment, all of you should know. Either you autoclave at 121 degrees centigrade for 30 minutes with a pressure of 15 pounds in 20 minutes, or soak in 2% glutathione for 10 hours. Or high level disinfection, you can do either rolling boil for 20 minutes or soak in 2% glutathione or chlorine solutions for 20 minutes. Then come to the second trimester abortion. If it happen, we all know that major 2/3 of complications occur during second trimester abortion. So we have option either surgical method or miscellaneous. And here again, the cervical preparation is very important. And all second trimester abortion should be done at the tertiary center. And you have to check whether your center is also permitted or not. Counseling and clinical examination in indoor care is recommended. And of course, by preparation of misoprostol, cervical preparation, the administration of misoprostol, it leads to contraction of uterus even before the actual procedure is initiated. So reduce amount of blood loss, possibility of perforation and time taken for the procedure. So it is always important you give 400 microgram vaginally 3 to 4 hours
Sorry to
prior
interrupt you, ma'am.
to
Your time
procedure.
is up.
So this was all about the first and second trimester abortion. You should be familiar with management and of perforation as well as hemorrhage. So in the last, I just want to share that महिलाओं में जागरूकता की कमी. So we have to provide the proper care and proper clinical as well as legal care to our adolescents, so that they can get the proper services, and safe abortion services should not be jeopardized in any cases. So we should update ourselves, we should update our clinical as well as our legal part, and we should provide some good abortion services to our adolescents. Thank you.
Thank you so much, ma'am. And that was a really very wonderful presentation to cover such a huge topic in prescribed time. Really hats off to you.
Bharti is well versed at some basic and she just went on like a kid recites the tables.
Yeah,
So
you are a
would the
master of
chairpersons
MPP.
like to make any closing remark before we shift to the next session?
Excellent, ma'am. It was very excellent, madam. So, but it is a very good, informative, and elaborated. All the forms and very well
Thank
explained,
you.
madam. Please share your slide also.
The
Time
whole
is short, but it
session,
is a very good.
Supriya, the
All the
whole
sessions
session
are
was
very good.
very
All are very
engrossing.
good.
We just stuck to the
Or the prepared is very good, no? There is adolescent
Yeah.
sexual violence, then the
Yes.
result of
Topics-
pregnancy, rape,
topics
and
were too good.
MTP and contraception.
Very
All are very
methodical.
good, very good, excellent. Thank
So
you, thank you so much, ma'am.
Thank you so much to the chairpersons as well as to the speakers. We'll now go to the final session for today, and that is the mentor-mentee session.
Yeah. That is
And for
more,
that-
I think, very interesting session.
Yes, and I would like to invite
Girish.
my dear friend, philosopher, guide, and brother, Dr. Girish Mane, to moderate this session. He is a past chairperson, Adolescent Health Committee, FOXY, 2019 to 22. Past chairperson of Adolescent Health Committee, AMOX, for 2 terms. Winner of the Best Committee Chairperson, FOXY, and a very active member of the Yavatwan OBGYN Society. His list of publications, presentations, and awards is endless. A very, very accomplished, I can say, adolescent health crusader. Girish, the session is all yours. Please do introduce us to our
Supriya, may I
mentors for
interrupt
today.
1 minute?
Yes, sir.
Yes, sir.
We all have cut down the time of Girish by 25 minutes. So I appeal that let some stretchability be there because all stalwarts are there in this session. And this session is really very much fruitful for us, all of us.
Yes,
so
sir.
It is now 6:25. The time limit for Girish is 6:50. So he cannot manage. So please extend it because we have taken their time. They have not taken our time. Okay.
Yes, sir.
Sure. So
Yes,
thank you very
Girish, all
much.
yours.
Yeah. So good evening, ladies and gentlemen. And I would like to extend my sincere thanks to Dr. Parag sir, Chairperson of ICOG, Dr. Sarita Madam, Secretary ICOG, and today's convener, Dr. Durga Shankar Das, who really gave me this opportunity. And my dear sister, Dr. Supriya, coordinator for this program. Supriya, many congratulations to be the unopposed chairperson of this Adolescent Health Committee. Then I want to extend my
Thank you so
sincere
much.
thanks to all the speakers, the chairpersons, the organizers, all the aspirants of this certificate course. And I wish a very happy Ganesh festival to all of you. Friends, as you all know that a mentor-mentee relationship is nothing but a professional and often a personal alliance where an experienced and knowledgeable individual, that means the mentor, who guides and supports the less experienced person like me, means mentee, in their career or personal development. It's a relationship which is built on the trust, respect, and mutual learning. The mentor is always a guide, offering their advices, sharing their expertise, and providing the different perspective. They act as the coach, they act as an advisor, they are providing us the many, guidances. They are our role model, and they are providing our with the resources and advocacies. So may I request the organizers to pin my mentors today, and I would like to invite and welcome our mentor for today's session, respected Dr. Suchitra Pandit Madam, Dr. Rosa Ulai Madam, Dr. Padmini Prasad Madam, and Dr. Shama Kanungo Madam. Please pin all these people. Hello, organizers, please pin all these guys. I will read all CVs from my side. Don't worry.
Can you just pin all those 4 mentors that are there with us? ICOG team?
5 people, myself, Dr. Rosa Madam, Dr. Suchitra, Dr. Padmini Madam, and Dr.
Kanungo
Madam. Yeah, please pin all these 5. So I will introduce Shama Kanungo Madam to all of you. She is ex-professor, head of the department in OBGY department, come superintendent in SCB Medical College and Hospital in Cuttack. She was ex-president of Association of OBGY Society of Odisha. She is ex-state level master trainer of ARSH in Odisha, master trainer in BEMOC USG. Then she is ex-coordinator in the Suman project. Then ex-counselor of ARSH and a program in charge of the postgraduate diploma in maternal and child health. Also in Indira Gandhi Open National University, and she is a convener of Integrated School Health Program, Sri Aurobindo Integral Education Center of Odisha. The second speaker with us, or second mentor I can say with us, is respected Dr. Padmini Prasad Madam. She is the first qualified woman sexologist from Karnataka. Then she is medical director of Ramnani Nursing and Maternity Home Institute in Bengaluru. She is founder president of Bharosa Charitable Foundation. She is chairperson of Family Planning Association of India in Bengaluru in the branch 2022 to 2027. Vice president of Council of Sex Education and Parenthood International from 2020 to 23. And she is a member of World Association of Sexual Health and faculty in many national and international conferences in the sexual medicine programs. The next speaker with us is Dr. Suchitra Pandit Madam. Everybody knows her. She is consultant in Surya Group of Hospitals, Mumbai.
Foxy representative to SAFOX in the current year, that is 2024 to 26. Then associate member of FIGO Ethics Committee. She was president of Foxy, president of ISOPAW, president of Gestosis, president of ICOGs. Almost, I mean, there is no post as a president which madam have left. And today we are getting pearls of wisdom from Suchitra Pandit madam. And the last mentor with us is a very beautiful lady whose name is just like her beauty, that is Dr. Rosa Olai. She is director of Olai Hospital, Gwalior, MP. Right now, madam is president of OBGY Society of Gwalior, state coordinator for Foxy Adhuna program, which is run by Bill Gates Foundation for 2024 to 26. She is member of Medical Advisory Panel, Family Planning Association of India, then chairperson of SBC Madhya Pradesh. She was vice president of Foxy in 2014, and she was chairperson of Adolescent Health Committee of Foxy in 2012, and she's a recipient of Best Chairperson Award in that during that year. There are so many awards in the name of Dr. Rosa Madam. For example, Dr. DC Datta Prize, Dr. Mary Tia Prize, and she had more than 100 publications, and she has authored many books also. So friends, actually we are dealing with very important topic today, and we want to know many facts and the experiences from all these mentors. So Dr. Suchitra Pandit madam is a little bit, she has to rush for her travel. So I think we should start with Suchitra Pandit madam. Madam, everybody knows that substance abuse, especially the alcohol, the smoking, or even the drugs, they are not good for health as well as for the future of adolescent. Even they are harmful for the family, even for the society, etc. And if they don't have any positive outcome in any way, then my big question with you is that when everybody knows that the sad is bad, smoking, alcohol, and drug, then how these adolescents they are getting trapped into this?
Yeah, very, very important thing. Everyone knows about the bad effects, but unfortunately, there is something called as a peer group pressure. Today, you notice that amongst the young children, young adults, I would say, the peer group is so high that, they feel obligated to say yes to whatever their friends say. And sometimes the friend, there are some of them who are not, they're already into addiction or they're already into substance abuse, so they tend to sort of coerce them and saying that it's cool, it's you have to be in league with your age group, and if you say no, they classify you as boring, or they leave you out of the group and they say, oh, you're just too dull, you can't be a part of us. So because of that, these young kids sort of, they that peer group pressure is so high. So, and what I have seen is in young children who are coming from disgruntled families. When I say there is a marital discord between the husband and wife, usually these children feel neglected, and they tend to succumb to the peer group pressure. And thirdly, what we feel is sometimes a very dominating mother or a very dominating father, or someone in the house who's constantly telling them, don't do this, don't do this, don't do this, do this, do this. So then what happens is they become rebellious, and then they feel, oh, this is my way of an outlet. So that's why they then succumb to the peer group pressure. And many a times, that's why we always say, choose your friends. The parents should know what those friends are, because the friends are the ones, if they think alike, they've come from families who have got good values, they've got strong family values, strong amount of confidence, then these children don't succumb. And Girish, another one group which succumbs very easily is somebody who has got a lack of confidence. Somebody, they're nervous by nature, timid people. Immediately they feel, oh, I better say yes to this stronger person, and they succumb to the pressure. So despite knowing that, they fall into that trap, and then it just goes on and on and on. Unfortunate.
Correct. And there is something called as, madam, peer rejection also. For example,
Yes.
yeah, some group of your friends, they are doing something, and if you are not doing that, so there is a fear rejection also. Of course, that plays an important role. Also, the family structure also plays a very important role. For example, the single parent, not to have the siblings with them. There is nobody to share their experiences or whatever they are facing. So, madam, how we can overcome this peer pressure? What should be the attitude of that boy or a girl to come out of this peer pressure?
So I think first is let me start, let's look at the parent side of it, then we'll go to the children's side. I think the parents should be involved, no matter how busy the mother or father is. One of the parents should be involved in the daily activities. When I say involved, doesn't mean you're tracking down each and everything, but just keep a tab of what the child is doing. Who is the child mixing around with? Are they doing sports? Are they doing going to the colleges? Are they just sitting around and doing nothing? Because if they get involved, then they know. Again, knowing the friends. So as I said, when you know the friends around you, how they are, then they can start, okay, this person doesn't seem to be good, so give a warning, try to find out more. And instilling that confidence in the children that, look, our family values are strong. I have never done that, so I would be very happy. There are disadvantages of this, so I am your friend, I'm a parent, I'm your mentor, I'm your guide. So if there's any problem you have, please come and talk to me. Don't feel shy. Supposing they make you drink alcohol and you've drunk by mistake, come and tell me. Don't be fearful. So that kind of the parents get more involved, they will, it'll be helpful. And particularly it could be the mother or the father, either ways, or even an elder brother who could be more involved. And from the children's side, again, let's look at the whole circle. If the child has got that natural confidence and has got that values, no means no, say it assertively, so they can say no. Just because there is a peer group doesn't mean that you have to succumb to it. Second thing, it's cool to say no. It's not always cool to say yes, is what we have to teach our younger people. Say no, say it with confidence. Third is, you don't get left out just because you're not a part of the group. There are so many things, and today, the children are addicted to mobiles and to laptops and to all the techie worlds. They don't want to go into outdoor games. So I think getting involved, physical games, whether it's a badminton, kho, swimming, whatever, that physical game, always keep your mind energy very strong and positive. And fourth and most important thing is, if they feel that they are getting into that trap, they're always an early stage. At that time, contact the parent, take the parents into confidence. If you feel the parents are too busy, then ask your teachers. There are, in all colleges, all schools today, there are counselors. Speak to them. And if not, nobody's around, today we've got very beautiful websites where they can talk to somebody who can give an excellent advice. But I feel the parents should be the first line that they should come to. That's why today I always urge all my younger patients, parents, relatives, please take your children into confidence. कुछ भी हुआ तो let them come and you be the first person that they knock their doors on and they come and cry on your shoulders, so that you can help them the most. So, and I think we as clinicians, we have to encourage all the younger people who come. Many times patients come, young boys and girls, they come and talk to us. Girish, you also have been, you've seen adolescent, they come and talk to us. At that time we could give them that proper advice. It's not always a moralistic advice, but an advice. Look, if you do this, there'll be so many consequences happening, so why get into this trap? Avoid this. These are the side effects, these are this. And gradually, I think these kids can definitely be prevented from the peer group pressure.
Yeah. So there are three basically type of peer pressure. One is the neutral peer pressure, where we just watch the mob and we try to follow them. Then there is some positive peer pressure, where my friend, he appeared for some course and he got some good opportunity, so I am doing that. And there is something negative peer pressure, where the boys and girls, they start drinking alcohol and doing something like that. So definitely we can use that positive peer pressure. So how the parents, the teachers, the friends, they can use the positive peer pressure?
Yeah. So I think parents, one is giving them good values. And in school, the teachers, when they talk, instead of just teaching them physics, chemistry, there should be a special class. I think very important, every school or every college should have that place where you are telling them social values. What is it to be a good citizen, a responsible citizen? And one thing which is there, Girish, in the earlier stages of substance abuse, nothing happens, probably the children look absolutely normal, but gradually there is that sense of they're losing attention. When they start getting dependent, you start knowing that they're disinterested in things, they'll quickly switch off conversations. That is the time when they're getting dependent. Then is the case of tolerance. They go into the tolerance, and finally it's addiction. So addiction doesn't come on all of a sudden. It can happen once in a way with drugs, which are given for some medication, some medications like antipsychotics psychotic drugs, so sometimes. But normally, in the normal course of events, substance abuse doesn't just start off. So parents should be able to pick that up, or the teachers should be able to pick that up, and rather than keep quiet about it, approach that child very confidently, take that child into confidence, tell the child what are the values, the positive counseling is to be done, and tell them that, look, I'm there for you. Let's get you out of this. If you feel you cannot do without it, let's go to a proper, there are so many rehab centers which, if you go in the early stages, they can do wonders, and the child is totally out of it. I mean, a very good example is Sanjay Dutt. In his earlier times, he was in a very bad group, and when his mother found out, these kids were taken to the rehab group, and this child was a Sanjay that got out of it. But another very famous gynecologist's son could not get out of it, and unfortunately became an addict. And Sanjay that got out of it. And the reason I'm telling you this example is, this abuse can happen at any stage, and therefore that positive, what you said, very important. That positive counseling is so important. And Girish, our olden days, we used to have those family outings, family get-togethers, family holidays. Today, children, the parents should take their kids out for a common, even it may be for a week or a 3 days or 2 days or whatever. Take them, get them involved in the family functions, like the Diwalis or Ganeshotsav or whatever, so they get that sense of responsibility. Get them involved in some kind of a positive activity, and that will be a way of doing it. Getting involved in community work. South Africa has got beautiful avenues for children to do the community work, and I think that is something which we in India, the Rotaries do it. So something we should inculcate. Get these kids involved in community activities. It goes a long way. And then once the kids are, they are sure of themselves, they can be our peer leaders to help us to treat other. When I say treat, not exactly treat, to dissuade other children. So they are the positive peer leaders.
Thank you very much, madam. And one more example of positive peer pressure is myself. After watching you, Rosa madam, and everybody, I came in Foxy. Probably that is a good example of positive peer pressure. So thank you very much, Suchitra madam, for your advocacy. So now it's a turn of second mentor, Dr. Rosa Olay. Ma'am.
Thank you, Girish. I just wanted to say thanks to all of you, Supriya, yourself, Sarita, Parag, and everybody who's organized this program. I will have to go in because I have to
Yes,
also
ma'am.
board a thing. Thank you so much. Thank you.
Thank you so
So,
much,
Rosa
ma'am, for
madam, I will
joining us.
directly come to the subject because we are short of time. My
Absolutely,
question
yes,
to you
that's
is, ma'am,
right.
how does one should approach to a school or a college for having these kind of sessions? For example, on the adolescent health. And is it good to have the boys and girls together in a same session? Just try to stick on the time. That's my request.
Yeah, I think, we have to be crisp because the time is short for you. So, Girish, very good question. And I think this is going to be helpful for most of us to understand that when you approach a school, basically it's your own town. So the people will know you. However, you need to be introduced on a letterhead. Maybe it could be a hospital. Maybe it could be Foxy or some organization of a, committee. During my term, we used to give, the chairperson's letterhead. So once you approach to school, you will have to be very clear in what you're writing. You're going to cover up physical health. You're going to talk about social health. You're going to talk about mental health and spiritual health. I know most of the schools, Girish, now they're starting with a junior youth empowerment program. Actually, we have a school in Gwalior, the Little Angels High School, where my sister runs up, the school, and we are doing this junior youth empowerment program where it deals with a lot of mental aspect, community service aspect, and spiritual aspect, which I think is wonderful. Time is short; I won't go into detail of it, but those interested can, get in touch with me. I can tell details of it. However, when you go to the school, the first thing the principal will ask you what you're going to talk about. So it's always good to pick up a subject. Now, if it's a girls' school, it's very easy for you to start with, for example, menstrual irregularities, PCOS, which is PCOD, which is on the rise. But sometimes, Girish, as you mentioned, there are boys also. It's a co-ed school. So what we have done for the years together, and for all those who are listening to us, it's always good to go with a pediatrician, friend of yours, colleague of yours. Because what happens is, if you're talking to the girls very private issues like by discharge, menstrual cycles, they are not very open. You cannot be comfortable talking when the boys are sitting. You know, that age group, they laugh, they tease each other. So what usually is done in experience all over the country, I've seen most of the colleagues take their pediatricians. The boys have got their own session, and mind you, what we just talked before with Suchitra's session, most of the life skills are taught with a pediatrician. So their organization has got this life skill, empowerment program where it talks about peer pressure, it talks about bullying, it talks about, communication. So basically a gynecologist and a pediatrician can go hand in hand, because just alone we do not do that. You know that, Girish, we still haven't brought up life skills, but the pediatricians have. So in short, it's always good to go with a team forward.
Right. Which common health issues should we discuss in the school? And have you ever noticed the changes in the behavior or the confidence level of the students after your session? I mean, what is your personal experience?
Yeah, so over the years when I was, you were involved in all the activities we have done, and you yourself have won a Best Committee Award. So you've done such great work yourself. But what really happens is, based on what matters that we give to our, your question was basically about the material that we use, right?
No, yeah, material
How
as
the
well as the
changes,
sessions.
the
I mean,
changes.
whatever you are, giving the lights to the students. Have you ever noticed the changes? I mean, is it worth?
Over the years, I've seen the type of questions they ask. And, we go basically with health issues in general. Or maybe we can pick up a topic like PCOD or PCOS. But the questions come out to be more than that. It's about, if you're telling us to take an OC, the hormonal contraceptives or whatever, my mommy says that later on it will affect me in future. So, the kind of understanding now I see with the amount of questions they ask is absolutely changed from what I was saying in 2012 to what it is right now. They are more careful, they are more AIs, artificial intelligence savvy and chat
Google University.
GPT, and they come up with such questions that most often I have to talk about these aspects and tell them, no, don't go there. Come to a gynec, come to a counselor. So there is a definite change, which is sometimes you have to be very careful, Girish. It goes in a very negative way.
Okay. Madam, I do remember that you had one study survey and you presented probably in FIGO World Congress in 2012, and we are proud of that. And congratulations for you for that also. So can you please share some highlights of that study in this program?
Yeah, so Girish,
everybody should know about that.
Thank you so much, Girish. The study was basically done with 5,000 students from different states of India.
Yeah.
It was Madhya Pradesh, it was Bihar, UP, Maharashtra, and Tamil Nadu. It was an only girls' college. So we try to understand what is understanding of the girls, how they behave towards sexual reproductive health. So when we made a questionnaire. So we gave this questionnaire to them and they had to fill it up. Like, for example, one of the very important part was, if you get your first menses, when you got it, how was your reaction? Was it very scary? Was it very happy about it? And you won't believe that majority of the girls, they were saying we were scared. So when we talk about if you had your first menses, you had pain and everything, whom did you talk to if you have any issues? So you won't believe, basically after the mothers, it was the friends. So that means a peer pressure here and understanding that how the friends can tell you wrong things. Then again, their understanding towards menses, hygiene, it was very much less compared to what we were expecting. So the committee started talking about these things more in schools. And then the interesting thing was, how do you spend your time? So the question was, what do you do the whole day? Majority of them wanted to listen to music. And and they were spiritual, like prayers and meditation. And when we asked them in this survey, what would you like us to come with later on? They said stress management. I'm talking about this in May 2012 during the...
So what was the age group of that?
Sorry to interrupt you, sir.
11th
3
onwards.
minutes left, sir.
11th onwards, 11th grade onwards.
No, not possible. We still need at least 20 minutes. Yeah, madam, please.
So let's go on. So it was spiritual health. And this is a change in these girls that we see, that they're enlightened to hear to these things. And when we talk about what do you mean by spirituality, it was basically what we taught them was moral values, patience, respect, vinamrata, humility. This is what we try to teach them, moral values in spirituality. It was a wonderful experience.
Great, great. Great to know, ma'am. Thank you so much. So as we got the warning bill from the organizer, I think
Girish, first of all, I want to
thank you.
congratulate you. Let me say, I want to congratulate you for conducting this questions that you did. And there is a video film which we give usually before our talks. What I'll do right now is I'll share the clip which is about adolescence. It covers a lot of issues in the message group. So those who are interested, you can play this in your talks before you give a talk. And again, I want to congratulate Supriya for becoming the future chairperson of the committee. You will shine, you will do wonderful work. Keep up the good work which Girish has built up. You worked with Girish very closely and he's a very good mentor to you. I know that. All the very best. We're all with you. At the same time, I want to even congratulate Dr. Parag and Dr. Sarita, who were able to organize. And Dr. Durgesh, let me tell you, Supriya, take him in your committee. He's a good person. He worked with me, very hardworking, very focused, and he was able to pull me up to this session. Take care. All the very best. Take care.
Thank you. So moving, and my personal heartfelt request to the organizers, please give me 20 minutes because yet Dr. Shama madam and Dr. Padmi Prasad madam, they are yet to express their thoughts, which is very important for, I think, everybody, every aspirant. So moving to Dr. Padmini Prasad madam, good evening, madam. Madam, I will directly go to the question. What type of sexual assaults usually happens with the adolescents? I am talking about the adolescents. What kind of sexual assaults? Padmini madam. Madam, please unmute
Padmini,
yourself.
unmute yourself. Unmute yourself, Padmini.
Unmute. Yes, ma'am, please.
Namaste to you all. Thank you very much for this wonderful opportunity and special thanks to Dr. Durga Das, Dr. Girish Mone, who interacted with me and a discussion of very important topic and also wonderful lectures by Dr. Durga Das, Jairani about adolescent sexuality and sexual assault. So there are varieties of, in his definition also, Dr. Durga Das was telling what is this sexual violence and how it is defined. So though rape is the most heinous crime and extreme degree of sexual violence, starting from the minor degrees, even like ragging, stalking, trafficking, prostitution, and incest. And that is also another heinous crime, rape with or the sexual abuse by the own relatives, and obscene phone calls, obscene messages, and cyber sexual assaults. And you know, this is becoming really very important and it is increasing in incidence. So these are all varieties of sexual assaults an adolescent can go through.
Yes, yes, yes. Madam, how these victims they suffer after these kind of crimes?
Yes.
What are the problems they are facing?
I will straight away come to this sexual assault and rape because that we were discussing and how to examine. And in his lecture, Dr. Durga Das so importantly are all the important aspects and all the effects and examination he had depicted. And though all the doctors are concerned with the immediate examination, treatment of injuries, infections, and prevention of pregnancy, and also this all this collection of samples. So those are all the immediate things what the healthcare professional is doing. But they should also remember there are immediate or short-term effects of rape or the sexual abuse, and also the long-term effects, which no one will usually give so much of importance. Even in short-term effects, apart from these physical injuries, genital or extragenital, and with additional injuries when they are pushed, dragged, or stabbed, or gunshot wounds, there are all additional injuries. There are also extreme degree of emotional problems, psychological problems, and the things like that. This is a short term where the varieties of psychological effect like fear, nightmares, sleep problems, anger, frustration, guilt, embarrassment, crying, shock, all this we can see in the victim in this. So in a similar manner, there are long-term effects, which every healthcare provider should know Apart from these long-term effects of infection, pregnancy, and other problems, there can be behavioral problems, psychological problems, academic failure, antisocial behavior, and what we call it as PTSD, like nightmares, guilt feeling, memory loss, shame, insomnia, in the long term, post-traumatic stress disorder, and the effect on sexuality and marriage, the future problem, and effect on the relationship. These are the long-term effect which you have to look into. And when I come to sexuality and marriage problems and the relationship problems, one or two examples I'll give you if you don't mind.
Yes,
So,
ma'am.
one patient had come, one couple, and I can call them Suma and Suresh. They are married for 2 years, and it was a non-consummated marriage. They had come for infertility treatment. So when I went into the history, deep into the history, then I found out that she was sexually abused by the teacher. So she had so much of fear, and then discussed about the sexual relationship. She had developed severe vaginismus. That was the reason. So when we detect vaginismus and the cause for infertility, that is the time you come out of this. Because she had not disclosed it to anybody, she had kept it to herself and carrying that guilt. Another one married for so many 3-4 years marriage, and the husband they came to me and they brought the wife and told me she does not have interest at all, doctor, and she is not cooperating with me for sexual relationship. Then when I asked her, when I sent the husband out and talked to her, then she told me, she only in one word, all men are dogs, because she was abused by the father, abused by the uncle, and she thought at least her partner would give her a good life and treat her in a good manner. But that husband also was found to be an abusive husband. So that she had that feeling in her mind. So all men are dogs.
Yes.
And another one, the mother brought child. So, doctor, she has developed bedwetting only from recent the 1 month. She has developed bedwetting, and she screams and cries for no reason. And I was thinking, I don't know, everything is okay in our house, and why she is behaving like that? Because she does not know what had happened to her daughter, and in a party she was abused. So these are all some of the examples I can give you how they can suffer in the long term. So the other effect on the sexuality can be unwanted sexual behavior in children, masturbation and adult talks, and then abusing other children, fear to get married. And so many couples, so many people have come. My daughter is not willing for marriage. She refuses to get married. And when you ask them, she says, no, I hate sex. I don't like it, because she was abused. And this vaginismus, infertility, and varieties of sexual dysfunction like decreased libido and anorgasmia, dyspareunia, and vaginismus. These are all the varieties, and it can also cause partner sexual dysfunction. So when the husband comes for erectile dysfunction, you can find out that the problem is in the wife. So these are the examples I can give you about what happens, whether it is the short-term effect or the long-term effect.
Again, there are changes in the behavior of that girl,
Yes.
irrespective of their family or the society. For example, we can take the example of Fulan Devi, who became rebellion after that sexual violence.
Yes.
What she did, everybody knows. Now, my
So
next
that is
question is how to go for the long-term rehabilitation of the sexual assault victims.
yes.
Yeah.
So this is what the long-term rehabilitation. First of all, everyone should know how we have to sensitize the healthcare providers, the police people, and the court and the law, and also the media and the public or the government NGOs, whoever it is, because how they have to deal with that. Earlier, it was taken more as a taboo and with a family honor, and the girl was ill-treated and looked down upon. But now the things have changed. And so girls, and after abuse, they're coming out and they're coming to tell people and they're disclosing what has happened. So the how they are treated, that is very important. And one girl who was abused just told me, one coach there, some doctors are there so rude and so insensitive, and that counselor told me, why are you crying? You are only raped. You are not dead. So these types of these comments also can happen. So the rehabilitation is extremely important apart from the immediate thing. Millions of women and girls are rape survivors. Rape can devastate individuals and challenge and change relationships in a million ways. So first we have to empower survivors and lessen negative symptoms after rape. So short-term psychological counseling and also the shelter, sometimes the shelter homes and rehabilitation centers, if the facilities are there. And we should have one-stop crisis center. So these are all the things which can help them in a very good rehabilitation. And in the later level, to bring them back to follow after 1 month, 6 months, 1 year, 2 year, and also tell them you develop any problem at the time you are going to get married, kindly come for a premarital counseling. So marriage counseling, sometimes the couple counseling, counseling of the partner also becomes very important. And if at all, if there are any sexual dysfunctions, you have to tell them that it can be treated. And nowadays, very good counseling and treatment are available. So we have to remove the guilt, shame, anxiety feelings from the girl. Tell her it is not her fault, it is the fault of the person who has abused her. So this is how we can give psychological support, marriage, relationship support. Thank you.
Thank you very much, Padmini madam. You have enlightened all our aspects in a very short, words and very with a huge meaning. So thank you very much on behalf of the organizers. Now moving to the teacher of teachers, Dr. Shama madam. Good evening, madam. Good evening. Madam, everybody knows that nowadays the spirituality, specifically in the adolescent or the youngster generation, what we used to have, the value, the moral value, the family values, even the spiritual values, what we used to have, it is totally changing. Now these boys and girls, they are getting addicted to the media, social media, and they are knowing the facts in the Western world more than what is going in our country, what is going in their own house. So do you think that this spirituality should be an integral part of ARSH training, and why?
Yes, thank you, Dr. Girish.
Thank you, ma'am.
Thank your whole team, Durga, for having involved me in this program. See, throughout in adolescent issues, we have taken only what the Western view has come, and we only treat the physical aspect, the sexual aspect, and at best the emotional aspect. But we forget that we are basically spiritual. Our country is spiritual, and this is what India has to give to the world now to save it. And entire Western world is turning to the spirit.
Yes.
As we have to include spirituality into adolescent health, because spirituality is an universal phenomenon and an inherent aspect of human nature that unfolds during adolescence as the individual searches for transcendence, meaning, and purpose. So we need at this stage to have a policy decision from FOXI, give it to the government of India to include into the vocabulary of ARSH some terminologies which existed in this nation for years together. We had a civilization, Aryan civilization, which was second to none. And we have to include certain Vedic terminology. The period of adolescence in the Vedic period was called Brahmacharya-shrama. Childhood Balyashram, Brahmacharyashram, Grihasthashram, Vanaprasthashram, and Sannyasashram. Everything was sacred. So this terminologies I wish should be included. And in the Vedic times, the adolescent was exposed to the knowledge of the three principles of nature also, and was asked to practice brahmacharya. So brahmacharya was nothing, it's not something moral. It's just raising your condition to a level of spirituality. It is a power, it is a capability. So right from the basic, the terms called jalas or retas was there, which by conservation it went to tapas, then to tejas, then to vidyut, then to ojas, and then to finally to virja, which means the divines, the Brahma's own capability can be given to a human being. So
Right.
these things are, we are closing the doors to the, the capabilities of an adolescent, of what he is able to achieve. And then he has to know that he has three natures, sattva, rajas, and tamas. What is sattva? Everything good is sattva. So he or she has to encourage to inculcate everything good. And the energy aspect is rajas. We need rajas, we need energy, but he has something called tamas, which is the negative side, the inability to change, and he has to drive it out from his nature. This was taught in the Vedic times to every adolescent. And then he has to awaken sattva, discipline rajas, and remove tamas. Then his studies, again, repetition, meditation, discussion. Repetition, meditation, discussion. Repeatedly, because Arjuna repeatedly practiced the archery when all other peers had slept, he could achieve such excellence. So if an adolescent's attention would be drawn to these things, he would not be, and about sexuality, they were told that this is placed in you by nature, and time will come when you go into Grihastha Ashrama only, it is sacred at that time.
Exactly.
Before that, it is not sacred, it will reduce your energies. These were told. And it's not moral policing. And then they were taught concentration, patience, and and they were also told about the energy chakras, the Sahasrara, Agya Chakra, Visuddha, Anahata, Manipura, Swadhisthana, which deals with generative health, then Muladhara, then the knees are Abachetana, below all Nischetana. So all these into energy centers, they were asked to bring in peace, calm, quiet, silence. Okay. And then the koshas were also told to them. The Annamaya kosha, Pranamaya kosha, Manomaya kosha, Vijnanamaya kosha, and Anandamaya kosha, which is there in Taitira Upanishads. It was taught to the adolescents at that time. And Sri Aurobindo has simplified everything. He said an adolescent has an outer being where he reacts, remains in his outer nature and reacts where he receives all the blows. But he can easily remain in the inner being, which is open to not open to external influence. He can coolly observe, he can be resilient, and he has time to rationalize and understand. Then he has something very inmost inside him, which will require practice. And if he does reach there, he will get a perennial source of energy, and he will know he always existed and will exist. Sense of immortality will come. This is possible to the adolescent. If these dreams are given, implanted in him, I think it should be very much a part of adolescent program in the entire nation today, where the whole world is waiting to take from India what they do not have. And it's important that in training and counseling it should be included. And that's all I have to say.
Yes, ma'am. So
Has
it is
some
not
PPT.
only the Hinduism or what the Vedas said, but in every religion, I mean, no religion on the earth teaches the bad thing, and they never promote the bad things or the crimes or the things which can be harmful to them themselves or the family or the society. So I mean, the student or the adolescent of every religion, they should be spiritual. They should be taught about the spirituality of their own religion. They can so that they can do the good things in their life. They can prevent themselves by going in a bad direction or in the wrong direction. They can build up their family. They can be useful, or they will do good things for the society. And definitely their future will be definitely brighter if they are having the spiritual aspects in their life. So I think this is these are the messages from our respected mentors today, Dr. Suchitra Madam, Dr. Rosa Madam, Dr. Padmini Madam, and Dr. Shama Madam. Thank you very much, Durga sir, for this excellent, this panel discussion on very different topic. And I extend my sincere thanks to all the mentors. Please keep advocating us, keep blessing us, and definitely we will have programs in future also. So over to you, Dr. Supriya Arwari.
Thank you so much, Girish. That was a very, very stimulating, discussion. And I think that was one of the best nomenclature to be given, mentor, mentee. So, with these kind of mentors always blessing us, I think we as the mentees are truly blessed and lucky to have such wonderful people, blessing us, guiding us with their vast experience. Thank you so much, Rosa ma'am, Padmini ma'am, Shama ma'am, and Suchitra ma'am. With this, I think we more or less come to the conclusion of today's session. It has been a wonderful experience for me as well. And I think there will be a post-test which ICOG team, whether you will be putting it in the
Let
chat
us
box.
proceed.
Yes, ma'am.
Yes. So all the delegates are requested to please check the chat box and answer the post-test questions. Meanwhile, may I request the convener for today, Dr. Durga Shankar Das sir, to please make his concluding remarks, after which we will wind up the session. Over to you,
We
Durga
have
sir.
made a principle that if we conclusion to be done, let the QR code be taken, and the policy has been decided not to disturb them when they take on the questions. Are you getting my point? Our students are very eagerly watching for this QR code to answer. So let us have patience to wait till then.
Sure, sir. Why not?
Supriya, after your talk, actually I was interested to add one thing. There are two kinds of nutritional problems
No,
today.
Girish,
One
let
is
us remain silent. It was policy was
Supriya
there
ma'am,
not
yes,
to disturb.
okay,
they
sure.
are saying silence, please.
Silence, please be maintained because they are disturbed. They will answer the questions now.
Okay, okay, okay.
क्यूआर कोड नहीं जो दिखे
वो तो ये कर दीजिए। वो चल चल जाएगी बसची तर कसं बंद करियो मैं तो गैस भाई को नहीं वो फैंडा
ICOG team, there is a query whether you can send yesterday's MCQ test link today. And those who want to watch yesterday's talks, how will they do it? How can they do it? Can the ICOG team guide, please?
no they cannot appear once it is passed is passed.
Sir, everybody and many of the people have finished with the this thing MCQ test.
No, we have to wait till the time report. I mean, Shreya reports that time is over.
Yes, ma'am. Sir, 2 minutes are left.
Okay.
Okay, you give us reminding that way, then display the answers. Then I'll go through that.
Yes, sir. Yes, sir. One minute left.
Hmm.
Is it over?
Yes, sir.
So just wait 1 second before you display the answer.
Yes, sir.
Just 1 second wait.
Okay, sir.
Now, attention participants, you have to remember that every day you will have to appear, and the exam that is once over cannot be given a second opportunity. So you have to qualify every day, making 50%. Okay. So this sort of request is coming on every certification course once the test is over. It cannot be given the second opportunity to any participants. Okay. So the message is every day you have to appear the post test and secure 50% on every day. And the qualifying candidates will be issued certificate within a month of closure of the certification course. Now you display the answers. I'll take one by one.
Yes, sir.
So we are very happy such a huge number of participants have participated. I hope all of you will qualify today. Maximum number of people will qualify today, but the reasons are obvious. I am not disclosing yet. Okay, let us come to question number 1. POCSO Acts concerns the following: girl below 18 years of age, girl below 16 years of age, both girls and boys below 18 years of age, none of the above. Answer is 3, both boys and girls below 18 years of age. Then question number 2, examination of a girl child less than 18 years who is victim of sexual assault is to be done by female registered medical practitioner only, female gynecologist only, any RMP who is consented for the purpose by the victim by a doctor, a female doctor in government hospital. The answer is 3, any RMP consented by the victim. Question number 3, if a girl child less than 18 years of age comes to us for MTP in our private setup, which of the following is true? Once police are informed, MTP can be performed even before police arrives for inquiry. Do not perform MTP unless police has arrived for inquiry. Do not perform MTP unless permitted by the magistrate. Refer the patient to government hospital for MTP. No, the answer is A, 1. That is, once the police is informed, MTP can be carried out. Question number 4. Adolescence in Vedic term was known Balyasrama, Brahmacharyasrama, Grahistasrama, Vanaprasthasrama. Answer is B, already madam has told, the Brahmacharyasrama. The vertical centers as described are Kosaj, Chakraj, Stitij, and Staraj. The answer is B, Chakraj. The number of horizontal areas of awareness are 3, 4, 5, 6. The answer is A, 3. Now the question number 7. Which of the following is not true for emergency contraception pill to sexual assault victim? It is also called post-coital pill. Not safe for HIV positive women taking ARV. No restrictions for medical eligibility criteria. Does not disrupt existing pregnancy. Answer is B, not safe for HIV positive women taking ARV. That means emergency contraception can be given to the HIV positive person taking ARV. Question 8. Which color top tube containing EDTA used to collect blood for DNA sampling? Black, red. Answer is purple. C. Answer is C, purple. Question number 9. Physical health consequences following sexual assault can be menstrual disorders, sexual dysfunction, miscarriage of the existing pregnancy, all of the above, none of the above. Answer is D, all of the above. Question number 10. POCSO Act is applied for doing MTP in age less than 16 years, age less than 18 years, MTP in non-married, all of the above. Answer is 2, age less than 18 years. which please question number 10. So now it is 11. Medical method of pregnancy can be given by registered medical practitioners, pharmacist, health worker, all of the above. Answer is 1, only registered medical practitioner. 12. The main aim of school health program is to give free uniforms to improve health and well-being of the school children, to train parents, to provide transport facilities. Answer is B, to improve health and wellness of school children. Question 13. Life skill education in a school focuses on writing and reading only, coping with stress, communication, decision making. C, computer literacy. D, sports activities only. Answer is B, coping with stress, communication and decision making. Then 14, miscarriage and relationship counseling is extremely important for sexual assault survivor. True or false? Answer is 1, true. Question 15. Sexual abuse can lead to sexual dysfunction after marriage, which cannot be treated. True or false? Answer is true, it is false. Question 16. Following are the risk factors for STI except multiple sexual partner, monogamous relationship, heterosexual relationship, sexual relationship without condom. Answer is B, monogamous relationship. 17. Which of the following have highest chance of STIs? Vaginal sex, anal sex, oral sex, masturbation. Answer is B, anal sex. Question 18. Which of the following can be transmitted sexually except hepatitis B, HPV, CHEV, HSV? So answer is CHEV. 19. Key principles of adolescent contraception counseling is emphasizing abstinence only, ensuring privacy and confidentiality, mandatory parental consent, discouraging LARC use. Answer is B, ensuring privacy and confidentiality. 20. A 16-year-old asks if an emergency contraception pill cause abortion. Correct response is yes, they are abortifacients. No, they prevent delay in ovulation. Only if taken after implantation. Only copper T iodides act after implantation. Answer is B. No, they prevent or delay ovulation. Hope all of you must have done. Now we'll come to the concluding part of our second day of the course. Now, again, at the outset, I express my deep gratitude to all the faculties who have done a tremendous task of giving a tremendous feedbacks and a great learning today. Let me start from the beginning. Let me start with Shupriya Arwari, who gave an excellent talk on nutrition. But Supriya, you provided to all of us a great antioxidant, not only to the adolescents. Thank you for your nice talk. But it was salivation uh, consuming, but it was excellent, great antioxidants. The second is talk was taken by Jerani. Very good, well covered. Adolescent sexuality is one of our great interest of making aware what Dr. Padmini Prasad told during her talk, that adolescents, uh, both boys and girls, must be very well informed about sexuality, and their conceptualization about sex can be very well removed by with a gynecologist. Then Apurva gave a full deliberation of STI and RTI. What are STIs? What are RTI? How best ABCD principle can be applied so that we can protect our adolescents. So also the adolescents will be aware of the consequences and negative impacts of RTI and STI. Basav told that it may not be a rewarding talk after Durga and Dilipji. Basav, you are wrong. This is the cream of the talk because all the adolescents nowadays must be thoroughly counseled and well aware of contraception. I hope, in my opinion, the most relevant talk of today is adolescent contraception. Dilip sir gave a very vivid, but thing is, medical legal issues are so important, so elaborate that it's hardly 10 minutes or 12 minutes can serve our purpose. Bharti Maheshwari did her job very well. Now let us discuss about the cream of our session, mentor-mentee. I am extremely delighted that this was my brainchild of conceptualizing mentor-mentee program. What a great deliberation we had from the stalwarts in the field. I am thankful, obliged, and bow down before them. Before I conclude, I'll say one line that we all gynecologists must be committed to promote the well-being of adolescents, to stabilize their mental strength, physical strength, social strength, and spiritual strength, to make them a very dignified citizens of Mother India. And I'll give another line of message. Any sexual violence occurs to any tender teen, we must be very tender to them. You should think as if our daughter has undergone such trauma, and we should pay the message that it is not a challenge or insult to your modesty, chastity, or dignity. Rather, it is a challenge to our dignity and honesty. We are there to protect you. Thank you all, everybody. Now, let us wind up the program. Thanking everybody at Team ICOG, all faculty, chairpersons ICOG, everybody, all faculties, and last but not the least, I give my deep gratitude extend to all the participants who have made this certification program such a great success. Thank you, everybody. Thank you, Supriya. Thank you, everybody.